Good afternoon. Today is July 27th, 2022. And since a quorum is in committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee at 4:06 p.m. As a reminder, some of our committee members may be also participating by video conference. So the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Members, we have a need to recess the strategic planning meeting and to go immediately into our Board of Managers meeting. I would like a motion to recess the meeting. So Dr. Bell and Dr. Valdez, both first and second, yes. Members, we will return from our recess. Oh, a vote, please. Yes, everybody vote to recess.
Aye.
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 Great. All right, thank you. So we have all the members agree. Yes.
Okay, managers. With a quorum of the board present, I would like to call to order the meeting of the Board of Managers. Today is Wednesday, July the 27th. And I just want to say, I think I got to all of you except one. We are clearly taking things out of order, out of our normal order this meeting. Our plan is to hear item number 4 on our agenda now in closed session, and then come out and take a vote if necessary, and then go forward with one other agenda item, which will be the Dell Medical School, and then we will go back to the strategic planning meeting. Okay, so I will read agenda item number 4. Agenda item number 4, receive and discuss updates on the 1115 Medicaid waiver, Delivery System Reform Incentive Payment Program, DSRIP, and associated projects, the Community Care Collaborative, and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas, and the University of Texas at Austin. I announce that the board is convening in closed session to discuss agenda item number 4 under Texas Government Code Section 551071, consultation with attorney. So we will now go into closed session.
Sorry, I'm texting some of the media.
Mute yourself.
Okay. Okay, do I have a?
I don't know. Hang on, 1, 2, no, I don't think he's 3. 4, no.
5.
5, she's back.
Okay. Members, can I get you to take your seats so that we can get started? After. Yes. For everything.
Yeah.
Okay.
Yeah.
Is that what you're saying?
Yes.
Okay, just wanted to-
Yes. Okay. We have discussed agenda item number 4 in closed session, and I am ready to take,
Kind of day.
I'm sorry. It is July the 27th at 5:35 p.m. We have ended closed session and had our discussion. I would like to open the floor for a motion from Manager Musaitif.
Are you ready? I move that the board delegate to the president and CEO authority to initiate or respond to legal proceedings with concurrence by the chair and vice chair regarding the matters discussed with counsel in closed session.
And do I have a second?
Second.
I have a motion by Manager Musaitif. I have a second by Manager Valadez. Any further discussion? Hearing none, all in favor?
Hi.
Aye.
Aye.
Any opposed? Any abstaining? Motion carries. Thank you very much, members.
Chairman Bell, did you get me?
Yes, I did.
Thank you.
We got you.
Thank you.
Can you make a notation that that was a unanimous?
Yes, that was the motion passed unanimously.
Thank you.
I'd like to bring up agenda item number 1. Receive an update from the University of Texas at Austin Dell Medical School on Central Health's financial investment and how it has contributed to fiscal year FY 2022 outcomes supporting Central Health's mission of serving indigent residents of Travis County, and an update on the University of Texas at Austin Dell Medical School future opportunities and challenges. Dr. George McConis and Dr. Amy Young will be presenting. Thank you very much for attending, Dr. McConis and Dr. Young. We really appreciate it and look forward to hearing your information.
It's on. That's on. Okay, well, thanks.
Thanks, everyone. Thanks for having us here today. My name is George McCones. I'm the interim dean of Dell Medical School, and I'm also the chair of the Department of Women's Health. And I want to introduce Amy Young. Sorry about that. Thanks. Who's here with us today.
That's Carol Gavazos, but
I'm trying to minimize this. Brianna. Can you move this off the screen?
I don't think I can because, oh.
That's
Is
good.
that good enough?
Yeah.
Okay.
Thank you.
And I also wanted to introduce Amy, who I think, Amy Young, who some of you have probably met before. Amy's the Vice Dean for Professional Practice at Dell Medical School and also the Chief Clinical Officer at the University of Texas Health at Austin. And that's our clinical practice. And we're going to be presenting together. And I just want to introduce a couple of other school leaders who are here with us tonight in person. Kevin Bozick is our Chair of Surgery and Perioperative Services and has done a great job with MSK, musculoskeletal care, which we'll mention a little bit later in the talk. Barbara Jones. Barbara is our Chair of Health Social Work, which is really a one-of-a-kind department in a medical school, and we're going to touch base on that later in the presentation. And last is Beth Nelson. Beth is our Vice Dean for Education and our Chair of the Department of Medical Education. And you're going to hear a lot about that today. And Beth oversees really all of our educational programs, our medical student curriculum, our graduate medical education programs, and continuing medical education as well. But again, I'm really happy to be here tonight. So thank you for the invitation to allow us to present. I want to especially thank Charles. Charles, thank you for having us. Thank you for taking the time to chat with me over the past couple of months. I really appreciate your approach to partnership, which is how we're thinking about this relationship as well. And it made it almost that I was looking forward to coming to this meeting. Almost, not quite, but almost. So thank you for being a great partner. So we want to take the opportunity tonight to talk to you broadly about what has been going on at Dell Medical School and what we've been trying to accomplish, broadly speaking, in terms of improving the health of the community. I know that's what Central Health is interested in our poor patients who really need us, and that's what we're interested in as well. But we're going to take a very broad look at that, how different aspects of a medical school, certainly our clinical programs, our educational programs, our community programs, and our research programs really sort of multiply to lead to a tremendous impact for the community. And we're going to spend a lot of time talking about that today. But I think this is a good time to look back over the past 8 years and more importantly, to look forward together to what we can accomplish. And I can say from my perspective, and I think from Amy's and other school leadership, other leaders as well, I would say first we view this as a partnership, and not as a transactional partner, but a real partner who both have the same goal in mind, which is to help to take care of our poorest patients. And I hope that we can take opportunities like this, to share ideas and to think about how to work better together to meet those goals. So again, a little bit perhaps getting away from transaction and getting more towards partnership. I just want to say a couple of words about who I am, since I haven't met any of you before. So I'm just by way of background, I'm an OBGYN physician, as is Amy. I'm from Philadelphia. And was there for all of my training. I was on the faculty at the University of Pennsylvania for 10 years. My specialty is actually taking care of high-risk pregnancies. And then I moved to St. Louis. I was chair at WashU in St. Louis for 14 years of OBGYN. And then I moved here because of what I saw as really a tremendous opportunity. Most of my career, or all of my career, has had a major focus on helping our poorest patients. And we had a lot of poor patients in Philadelphia. And we had a lot more in St. Louis, and we have a lot here. And really all of my clinical work and a focus of my research over the years has been on trying to improve the health of the underserved, in my case, in relation to pregnancy outcomes. So I was excited to come here because of that focus, and that focus comes from this relationship, I would say mainly, and now it's just sort of imprinted into the entire medical school. And the other thing that was really attractive to me was the newness of the medical school. And you may take that for granted, but I can tell you that trying to develop an innovative program in a 100-year-old medical school is impossible. We can't do the kind of things that we do here when there are silos that have developed over years, where there are financial barriers to doing those things as well. And I think that's what brought many of us here. I'm sure it's what brought Kevin here, what brought Amy here, and others. So those things have been really important to us. And I think that, again, that spirit of community and the spearmint, having the opportunity with newness has really allowed us to do some exciting things. So I'm really happy to be here. I've been here now for 3 years to the day, literally. Unfortunately, I was here for 6 months and then COVID hit, so things really got turned upside down. But we're coming out of that now, and again, really excited to be here and really excited to be with you all tonight. So again, I think not to relive history, but obviously there was a lot of thought and work that went into the development of the medical school, and I know that you were all intimately involved in that. But a lot of work, sort of looking at it from the outside, it was strange to have a city like Austin, with the capital of a giant state like Texas, where the flagship university sits, not have a medical school. That's very unusual. The only other place I could even think of that was similar would be Phoenix. Now they have 3 medical schools. But so clearly it was a place that needed to have a medical school and some academic medicine. And as all of you know much better than I, Prop 1 was passed in 2012. And then the medical school was started with great partners and really a view for the community. And that's what it says here, a medical school for the community, built by the community for the community. And our goal has really been to think about medicine in a different way, and thinking about healthcare and health in a different way than most medical schools think. And again, I would sort of go back to sort of those founding principles and the things that sort of make us a little bit different. Again, is community investment number one. I can tell you that is the fabric of our medical school, and it's what our faculty and our residents and our fellows and our students think about every single day. Again, we have a great, obviously UT Austin is a tremendous school, and we have a lot to be thankful for and leverage with UT. And lastly is, again, the newness and the ability to do things differently. So lots of exciting things, but starting a medical school is really complicated. And I'm actually sort of glad I wasn't here when it started, because I don't think I could have done it. I know I couldn't have done it. So I'm grateful to people like Amy and Kevin and to Clay, our prior dean, for doing that. It's also expensive. And in fact, I think that the Statesman a number of years ago estimated that it was going to cost $4 billion over 12 years to get the medical school off the ground. Just costs a lot to get things started. And obviously, everything that we do is built on partnership. Here are a list of partners. Obviously, Central Health Community Care are at the top of the list. We have a great partnership with Ascension Seton and Dell Children's, Michael and Susan Dell Foundation, who are great supporters of ours as well, UT System, the VA, Integral Care. And again, sort of trying to change how we take care of poor patients and improve the health of the poor, really requires an army and can't be done by one general. So we're really lucky to have you, of course, and all of our other great partners to help to make that happen. But we recognize that we've made, I think, a lot of progress since the school was founded, but we have a lot more work to do. We've only sort of taken care of a fraction of the work that we need to do together, and we need to problem solve and to move forward together. I did want to just take a couple of slides and talk about the agreement that sort of is the foundation of the relationship for our partnership. It's an affiliation agreement between 3 bodies: Central Health, the Community Care Collaborative, and UT Austin. And that last piece is not Dell Medical School, it's UT Austin. So this goes right to the president of the university, just so everyone understands. And that affiliation agreement between those 3 was signed in 2014 and has a 25-year term. And I know that you all have read this. I had never read it actually until about a year ago. It was interesting for me, and I thought I would just highlight a couple of things because I think it's just germane to some of the conversations that I know are in everyone's mind and are on our mind as well. So an essential aspect of Central Health's vision is the organization, construction, and operation of a medical school by UT Austin, UT system funding of 25 million per year for Dell Med plus 5 million per year for faculty recruitment, and a local community support of a total of 35 million per year for the direct support of the UT Austin Dell Medical School. And I know that you all know those numbers well. Permitted investments are essentially the way or the things that we can spend that 35 million on. And at least when I read this, I viewed this with that those permitted investments were very broad. They include the provision of direct operating support to UT Austin that will be used by UT Austin in its discretion to facilitate and enhance development, accreditation, and ongoing operation of the UT Austin Dell Medical School and its administrative infrastructure, recruitment, retention, and work of the UT Austin Dell Medical School faculty, residents, medical students, researchers, administrators, staff, and other clinicians, and then other related activities and functions as described in the agreement. And I would just say that that's broad. So at least in my view, those permitted investments are very broadly defined in the agreement that we are living by. So progress as partners, again, I don't want to sort of run through this in great detail. Obviously in 2012, Prop 1 was approved. The affiliation agreement was assigned in 2014. And then a whole lot of good stuff, I think, has happened in the years since. That includes Clay coming on board as our first dean in 2014. Dell Med took over the management of the residency program. So there were residencies here in Austin that were community-based that sort of transitioned to the medical school for its oversight. Our first medical student class started in 2016. So we've now graduated 3 classes of medical students. 2019, I'm going to point out the Department of Health Social Work was established, a one-of-a-kind department where we actually have in the medical school someone like Barbara and her team that provides care and really in all of our clinics, which our patients desperately need. And then in 2021, and we'll dig into this in some detail a little bit later, our GME programs doubled in size, which is great because our residents become really people on the front lines. And if there are a group of people more passionate about the care of the poor than our residents, I would love to meet them because our residents, like that is what drives them every single day. And we're actually super proud of that. And there are a lot of things that have happened along the way that are interesting and exciting. We've got some very interesting training programs in healthcare design and healthcare transformation that our trainees can avail themselves to. Again, Amy runs UTHA, which again opened in 2017 and is growing like crazy. So lots of good things have been happening, and we couldn't do it without partners like you, of course. So what does the investment from the community make possible? Well, I would say it made us, number one, as a medical school, and it's allowed us to really grow and to sort of multiply sort of the effect of that $35 million. And here are just some examples. We have 13 academic departments in the medical school. I would add that they are all clinical departments. So if you look at many medical schools, there's a department of biochemistry or molecular biology. We don't have those. We have clinical departments, women's health, surgery, internal medicine, neurosurgery, neurology. So again, we're a little bit different because we're very clinically focused in our department structure. We have 12 centers and institutes. We have 306 regular faculty members employed by Dell Med, although we work with many Ascension docs and docs from the VA as well. We have 825 staff members. And we describe some of our work as pillars, but I don't want you to think of those as sort of independent because they're all in a matrix of everything that we do every single day. And of course, that includes clinical care, research, and education. And I think many of you know Minnie Kalon, who is in charge of Healthscape. That's sort of health beyond the walls of the clinic and the hospital. And that's something very unique and we think brings something really different to the table for how we think about our community. Community investment's important, for education as well. And just sort of to remind everyone how sort of medical education works, someone goes to college, they graduate, they go to medical school, that's undergraduate medical education. You finish medical school, then you go on and you specialize in an area of medicine. So I did OBGYN, so did Amy. You could do medicine, surgery, whatnot. And then when you finish your training, then you move on to continuing medical education. And that's how we sort of keep up with what's going on. And CME was incredibly important through COVID as things were changing weekly with new recommendations. And we had to really help to keep the docs in Travis County appraised of what they should be doing and what was the latest evidence on different topics. And I feel like sometimes we forget about CME, but it's actually really important to help to keep docs up to date. Our UME program, so our medical student program, we currently have 200 students in medical school. We have 50 per year. It's a 4-year program. 94% of our students are from Texas. And I actually didn't know this, but you need to have 90% Texas residence is required by the state. So that was a fact that I learned in looking at and making these slides. 23% are URM. And that's a bit higher than the US medical school average. And we have 61% of our medical students are women, which is above the national average. GME has grown, as I said, out of control. We have 401 physicians in training. 21% are URM identified, which is significantly higher than the national average. And 54% are women as well. And then in the CME space, as I pointed out, it was incredibly important to keep our docs in Travis County up to date on what was happening through COVID. And we actually do some great town halls with Travis County Medical Society jointly with Dell Med. We did one last week that was focused on pregnancy and COVID, so I was super interested in that. But again, they were almost every week through most of COVID, and I think was a great thing for the community. Research is important as well, and again, everything that you contribute to us helps us to do that. We have $89 million in research funding. You can see numbers of investigators and projects. Without getting into all of these, I would sort of point to the first. We have a really tremendous person named Tim Mercer, who I hope at some point you guys get to meet. Tim has a joint appointment in medicine and in population health. All of his work is in what we call street medicine, taking care of the homeless. And he's probably one of the nation's experts in doing just that. A lot of people have donated to Tim for his work. He's got a very active research program in that space as well, but it's really about touching individuals and helping them with their help. So Tim is fantastic. I really do hope at some point in the future, you can bring him in for 15 or 20 minutes and hear about what he's doing. And the other one I would just point out is the overdose project. It's called Project Connect. Texas was really far behind in how they were reporting and tracking overdoses in the state, really compared to almost any place else. So a really good project was developed with the School of Social Work and Population Health that was taken up by Texas to really improve tracking and reporting of overdoses in the state. So lots of good work happening in the research space. So this slide, I think that you have seen before, or a version of this slide rather, you have seen before. Again, this is sort of a one slide overview of the budget, looking at fiscal year 22, which is not yet complete for us. So we're sort of an August to September 1st fiscal year. And then what we're looking at in fiscal year 23. This is about how the $35 million is spent. I wouldn't say there have been any big moves between 22 and 23. You can see that there are some things that are highlighted in orange. Those programs are supported in other ways, not using any of the $35 million, mainly some big philanthropic gifts that we've been lucky enough to receive. And again, on the right, there's a pie chart. So the medical school's overall expenditures for what we anticipate for fiscal year 23 are 302, a little bit over 302 million. And the funds from CCC are about 12% of that. So I'll stop there. And I think you all have seen these slides in advance and saw a version of this last year. So no big movement in anything really on this slide. And then I'm just going to run through over the next 10 minutes or so some examples of impact that we've had about doctors and the kind of people that we're able to recruit, safety net care, ways we benefit everyone in Travis County, work beyond the hospitals, and then addressing gaps. So first, I would say, things have gone great in terms of attracting docs. There's a doctor shortage in the United States, and we have, done really well in bringing in some really terrific people into Central Texas. So again, since 2014, we've been really directly connected to adding 415 new doctors. Here to Austin, 241 of those are sort of full-time Dell Med employed. The other 174 are really done in partnership for the most part with Ascension, where they're employed by Ascension, but they do report up through the medical school, and we're their sort of bosses in a clinical sense, I would say. And we've also recruited some incredible superstars here to develop programs that not many places happen. And I'll point to one that Amy and I worked together on in our department. We recruited 2 physicians who do what's called fetal intervention, which is when a baby has a specific kind of birth defect that we identify before delivery. There are actually things that we can, I don't want to say do to them, that we can do while they're in utero to improve their outcome. Things like fixing spina bifida while babies are still inside. And again, there's probably 12 of these kind of docs around the country, and we have 2 of the best. So we're really lucky to have that. They're at Dell Children's Hospital. It is a one-of-a-kind program. And again, Amy and I sort of worked on that together over the years. And I can tell you that, that there are a lot of patients from community care that have benefited from that service. I can tell you that literally the first patient that they saw was from community care with conjoined twins, which is incredibly, incredibly rare. That was never turned out very well, but it was a family that needed a lot of help, a lot of support to get through a very difficult pregnancy and come out okay on the other side. So I do feel like there's been great benefit from that program. And you can see that 42% of the people that we've employed are specializing in areas that are of need, as identified by the Equity Strategic Plan for Central Health. You'll see that women's health and MSK are not, musculoskeletal, are not listed on this as an area of need. And I would like to think it's because we did so much work on that at the very beginning of the medical school. So Amy gets A+ effort for that work in women's health, and Kevin does, of course, for MSK. And we hope that over the years, we'll see this list go to nothing. I know that'll never happen, but we want to keep checking off those boxes over the years to come. And then again, here are just some great programs that have been developed. So, over to the left, we have a superstar pediatric cardiothoracic surgery team here led by Chuck Frazier, doing incredible work at Dell Children's. We have an abdominal transplant program now at Dell Seton. There wasn't a transplant program in a giant city like Austin. Like, that's completely crazy. People are having to drive to Dallas or Houston to get a transplant, and we're looking to grow that program. So really trying to, to elevate what we can do here. There are a lot of great docs here already, but we wanted to add and be multiplicative to what we had already. Again, in terms of attracting top docs and training people, again, I think we talked about our medical student program a bit. I would just add that 41% of our medical students thus far, and again, we've had 143 actually graduate, 41% stayed in Texas, and about a quarter are staying actually in Austin, which is terrific. And we do even better for our residents. And I actually view our residents as more of a pipeline than our students. And you can see that here. Since 2015, we've had about 567 graduates from the variety of residency programs. Almost 70% are now practicing in Texas, and about 40%, over 40% are practicing in Central Texas. And that's great, because Austin is growing out of control, and we really need those doctors here with us. And that's better than most places. We've had a ton of growth in our residency programs. And again, I think our residents are incredibly important for coordinating, expanding our safety net care, not just when they're residents, but also a lot of them get really turned on by that work and then want to stay and do that work. And in our department, Amy and I have 3 docs who are staying here in Austin to do some of that work, which is great. Our residents and fellows do a ton of clinical work. You can see over on the left, they do like literally 730,000 hours of care. That's in 2022, and that includes 500,000 hours of care at Dell Seton, Dell Children's, SMCA, and at community care as well. And over on the right, if you look at the bar graph, you'll just see that there has been incredible growth of our residencies and fellowships since 2015, 80% increase, as we project all the way out to 2026, but through 2023, it's going to be a 55% increase. And again, lots of new residencies in ophthalmology, neurology, fellowship in GI, addiction psychiatry, incredibly important as well. And again, that's our pipeline. And again, we want to continue to really grow our GME programs. And almost all of our programs have some presence at community care or at the VA or both. And we're really happy with that. It's a great experience for them. And as I said, it can really get people turned on. Again, this is more about visits by our resident physicians at Ascension Seton hospitals. Again, let's just focus on the top arrow, which sort of includes all of the central market hospitals. Since 2019 to now, you can see that there's been a 300% increase in the number of patient visits that our residents are doing, up to 149,000 in fiscal year 21-22. So again, that growth translates into direct patient care and touching individuals every single day. We also have a great relationship with the VA. VA's got a very unique population, and there are parts of medicine that our residents can really make a great impact in. And I just met with the VA team this past week and chatted about the future and more things that we want to do. You can see that our residents are involved with over 11,000 unique patients and 31,000 patient visits at the VA. And community care is incredibly important to us. And again, I can tell you that in women's health, we have a number of residents every day supervised by our attending physicians who are providing care there. And then on the faculty side, we're also, I think really doing a lot of work for the underserved patients. This picture that you see, that's one of our women's health docs. That's Dr. Denise Johnson. She's an OBGYN physician. She trained at the University of Pennsylvania. She now helps to run our residency program. She is fantastic. We have, again, as I said before, we have about 306 regular faculty, and 65% of those do some work in the community. I'm an example of that. Every Tuesday morning, I go to Southeast Health and Wellness Community Care Clinic and see high-risk OB patients. And I think Charles and you came to visit me there one morning. And it's honestly, of my 5 days a week of work, it's my favorite half day. Is my half day at community care. We see a lot of sick people, and I think we actually make a big difference. And our regular faculty do over close to 300,000 hours of care, sort of focused on underserved. And UT Health Austin, this is sort of Amy's sorry. Okay, hopefully you have me back. 24,000 unique patients, 80,000 patient visits. And again, about 1 in 3 of those visits are Medicare or Medicaid patients. And we have a new ambulatory surgical center that just opened in 2021. It's been a little bit of a slow opening because of COVID, but that's really going to pick up, and we think it's going to be a great service for the underserved as well. And then again, sort of more in the healthscape realm that Minnie is very involved in. We have a great community health workers program that's run out of Population Health. We also have a cancer prevention and control program that we've had a few people who've been really instrumental in. This is really a partnership with community care. Again, initially around colorectal cancer screening and lung and alcohol related cancer screening, and you can see the number of people that have been screened because of that program. And it's actually, that program came to be from a grant from what's called CPRIT, I can't even remember what it's called, Cancer Prevention of Texas program. So we've gotten $8 million in grants to Dell Medical School to develop those sorts of programs, and they've been a great success. We're obviously very interested in mental health. We have a terrific psychiatry department and a terrific department chair in Charlie Nemiroff. We've been leading the ASH redesign in collaboration with Texas Health and Human Services. That's going to open in 2023. Super exciting, I think, for Austin. Travis County Forensic Mental Health. Again, that's about the intersection of crime, prison, and mental health. Again, also really important as well. And then lastly, health equity. I probably don't need to speak too much to you about that because you all know Jewel, who is our Associate Dean for Health Equity. Health equity is central to our medical school. It's as central as the care of the poor is to our medical school. And we're doing a ton of work in that space, and it's something that we're really incredibly passionate about. And I'm going to turn it over to Amy to
Sure,
walk through a few
thanks.
slides.
Thanks so much, George. So for those of you who don't know me, I'm Amy Young, and I'm the Chief Clinical Officer, and I was previously the Chair of Women's Health here at Dell Med, and I've been here since almost the beginning, January 2015. And so one of the, I think, the rewarding things about seeing a presentation like this and having the opportunity to speak to you all is that just to share the evolution and the growth that's been pretty phenomenal in a short period of time. I like George, I like warm weather, so I've never been in that Northeast area, and you can tell from my accent about that. But, I've been in places that have very mature systems and very mature hospitals. So coming here and having the opportunity to make impact and trying to provide care the right way to the right people at the right time is really a unique opportunity. So I'm really glad to be here today, and I'm going to tell you a little bit in a little more granular way about some of the work that we've been doing. For some of you guys that I've had the opportunity to speak to before, it'll look like an evolution or a work in progress, and for others of you, it may be very new. We'll get started there. I wanted to also just riff a little bit off of George in the health equity space, in that one of the things, we had a meeting with some folks from Central Health this morning, and we talked about the re-credentialing process that we put in place at UT Health Austin that requires DEI training as a mandatory requirement for people to continue to be credentialed and work with us in our environment. So I think that's one of many ways that I think we're trying to advance care. So to shift gears a little bit and to get a little bit more into the nitty gritty and some granularity of the projects, I mean, one of the things that we do together is really work towards developing an integrated care delivery system. And I think when you've trained in other places and you've worked in other places, especially in academia, those integrated delivery systems are already created, right? So we're all under sort of one tent, the clinics are formed, the relationship with the partners is there, everything has been well established. And so I would say there's some challenges and opportunities about being here and working in an integrated delivery system. So when you think about what an integrated delivery system is, to me, it is like a set of puzzle pieces that you have to cobble together in a way that you can provide coordinated care for patients across a continuum, but you do it in such a way that you can tailor it to the patient. And sometimes it's harder because there's more pieces that have to be put together. Sometimes there's gaps that you have to build that are just not there. And sometimes it's actually about putting the glue there. When I came here as a chair of women's health in 2015, I thought I was coming to do something very different than I did, and that was to create novel new programs sort of on top of an existing infrastructure, because I assumed that the care delivery system was fully integrated, and I would say that it really hasn't or wasn't, but especially I would say in women's healthcare, working together with you guys, we've made great strides, and I'll talk about some of those in a few minutes. So specifically, we'll talk a little bit about the COVID-19 response, and I think something that is a big win for our community. It was really the collaboration between us and Central Health, but many city partners that led to the outcomes that I'll share with you. I'll try to do justice to the Musculoskeletal Institute. It's hard to do in front of Kevin, so feel free to jump in at any time. I'll talk a little bit about the Women's Health Institute, which is really provides complex gynecology services in our community. While I do practice obstetrics, I don't practice at the level that George does. And so a lot of the other aspects of women's healthcare are really important to me, and I've had the opportunity to work in that space. And I'll talk a little bit about our GI clinic and the pilot that we did together and the successes that we had there. I asked to add this slide. It's not in the slides. Sorry. Don't need water. It's not in the slides. I didn't expect that to happen. That we gave you guys before, my puzzle pieces, sorry about that, are a little simplistic. I don't have COVID. That's why I missed the last board meeting. And I don't want to have it again. But the puzzle pieces I showed you is a very simplistic version of an integrated delivery system. This is actually the map that was put together with the consultants in Central Health of what it really means. So this is a very complex picture of all the pieces that interact and have to work together in an interlocking way to deliver care. And so the trick in all of this, to me, is figuring out how to make it work. The care is standardized in a way that you can make sure that you provide high quality care for everyone, but that you can individualize it enough that you can meet the differences that individual patients bring with them. Oh, thank you. But then I might choke and then we'd have a real problem. Oh, we have a surgeon in the house. It'll be okay. All right. But having said all of that, I just think I needed the humor to get past that. So this is the true picture. This is really how complicated it is. And so I think what we're all trying to do in the community is work together to make sure that we can individualize care for the individual patient, but to make sure that we can sustain that high quality, decrease the variability as much as we possibly can so that we improve care and create safe outcomes for all of our patients, but especially those that present with limited means, potentially issues with health literacy, et cetera. We want to make sure that they have a great experience and they have the same outcomes of others that come in with, different resources and, different tools to navigate the systems. So these are some of the clinical milestones that I think we've been able to achieve with you guys since the inception of the medical school. Like I said, I came in 2015 and realized that we needed to create some modicum of a integrated delivery system for women in the community while we were building innovation on top of it. And so that's a lot of the work that we did with you guys in 2015 and 2016. Again, we created some care standardization, but we moved care out to the patient. As George's experience that he has at Southeast Health and Wellness, instead of having all the patients have to come in. In 2016, Kevin's team did a really phenomenal job of reducing a wait list for musculoskeletal care. And I'll tell you more of that story in a minute. But we have both worked on bundles for complex gynecologic services and musculoskeletal care. And through a lot of work of a lot of people, I think that dot on this slide should be actually huge, is that we were able to actually open a facility so that we could implement those specialty care bundles. And we've worked with you on providing care in the complex gynecology space as well as MSK for the last 5 years. And so I think we've been able, and I'll show you the numbers of patients that we've been able to reach during that time. In 2019, we did a gastrointestinal pilot program really to improve access for patients. In 2019, we did work around postpartum pain management. You're going to hear the opiate story again today in this format. And then 2021, another really huge heavy lift is that we opened the ambulatory surgery center at UT Health Austin. And that's really important because it creates a continuum of care for patients that need surgical procedures. And it also has us move patients from a hospital environment to a surgery center where care is efficient, it's less expensive, it's safe. And I would say that both for the providers and the patients at this time, they have a great experience in this particular environment. And it's an area that we hope and are working intently on expanding with you. And then in 2020, COVID hit. When COVID first hit, I think I actually had the joy or I will actually say it was joyful of swabbing and testing the very first positive patient in Austin. And that's a whole another story for another day. But I remember shortly reading after that we would have COVID with us until 2022. And I didn't think there was any possible way. And here we sit with COVID still in our midst. We think about it differently. And it has a lot to do with the work that we've all done together in our community. And it's made a huge impact. And it's involved everything from testing to contact tracing to vaccine development. So a lot of the vaccine development was done at UT, vaccine delivery, all working together, and we're working together in an ongoing way. We've brought in therapeutics, preventive agents, and we've all done that as a collaboration. You know, the one thing about COVID, people always ask me what it was like to sort of be in my role as we've navigated this. And the truth of the matter is that most of the time, even though the work was really hard, it was really joyful. We had a really common enemy, and I think we made really great progress. And one of the things that when I've had the opportunity to talk to Jay Hartzell, that this is a carpe diem moment. We need to seize the day because we've worked together in ways that we need to continue to sustain as we go forward. And so I'll talk a little bit about that in a minute. So talk about COVID-19. I know everybody's tired of talking about it, but it is worthwhile to stop and actually look back and reflect on where we've come and the opportunities that we've had to really make a unique difference in our community. So if you think about it from the beginning, I talked a little bit about testing. You know, just a funny story in the beginning is that we had very little testing supplies and equipment. And one of the things that one of my colleagues at Seton told me is they reminded me that the swabs that we use in women's health for testing for STIs is actually the same media that we used to test for COVID originally. So we drove all around the city and got everybody's supplies so that we could continue to test for COVID in the beginning. Because of the nature of the work that we did, we had to develop contact tracing the next day. So all of a sudden, I didn't know how to set up a contact tracing team, but I had somebody on my staff. So we built it at UT. We were doing a lot of the contact tracing, and I think all of it for the city until Austin Public Health could catch up a little bit. And then we, you know, were pivoted and decided we needed to work in this capacity building space. So we had the community care, for example, folks come over and train with our folks, and then they went back to community care. So it's just been, you know, a rich example of that work from the beginning. And then for patients that were in the hospital, our hospitalist teams and our folks working in community care did a fantastic job of developing leading edge protocols and sharing them with the community. So we were some of the very first to jump on the bandwagon for steroids, and I think that resulted in some of the outcomes that you're going to see. The other thing that was really unique about all of these experiences is really to harness the wealth of all of the University of Texas. So one of the things that's made a big difference in our community is our ability to model and predict when our surges were going to come, when they were going to peak, what we needed to do to inform our community about behaviors that we needed them to adopt to continue to maintain at least some modicum of safety as we've navigated our way through that. If you think about the vaccination piece, I mean, one of the groups that is still going out and reaching out into the community is our VAMOS group that's really spearheaded by our nursing school that was an evolution out of the vaccine hub that we originally built. And then lastly, we are continuing to work with patients around long COVID. You know, we don't really have an understanding yet of the science behind the why, who's going to be affected, what we need to do to best treat the patients and sort of return them back to some, you know, modicum of normalcy for themselves and for their patients. And so working together with you and with others in the community, I think is responsible for the slide I'm about to show you. I'm not sure how many of you guys are aware of this, and the populations are not exactly the same. But, you know, Mike Giesland has sat on calls with us every day for a while, every week for a while. And now that we spaced out to every month, and now we're back to every week again. You know, thinking about what our community response needed to be to COVID. We've had the modelers there. We've had people that were experts in testing, and then we've built collaborations now around therapeutics with Ascension and with Austin Public Health. And it's pretty meaningful when you look at a slide like this and look at our mortality due to COVID compared to other major cities in the United States. And this just speaks of our ability to work together to improve the outcome of patients in our community, and especially those that were most affected and most vulnerable to COVID and to other illnesses and diseases. I'll try and do justice to musculoskeletal or orthopedics. I'm still sort of old fashioned, so I call it orthopedics. Kevin can get mad at me about that later, but we together have provided care now for more than almost, I'm sure it's more than 16,000 patients now over the last 5 years. And there's some things that are really remarkable about that. So almost this number will be close to 50,000 visits by the end of the year. Just this last year, we saw more than 6,000 unique patients, and we've had close to 15,000 patient visits. And so it's really had a dramatic effect on access for our patients. So this work started small. You know, this work started back in 2016. I showed that to you on the timeline, but Musculoskeletal did a pilot program, and they worked a backlog of 1,400 MAP patients on a waiting list. They've been on a waiting list for a year. And they worked that waiting list down over a period of 7 months. And even today, the wait list for an MSK patient to get into our clinic to get assessed from a referral is less than a week. Now, the patient may not be seen in a week because they have other things that they want to do and they want to postpone it. But if a patient calls, they can have an appointment within a week. That's huge when you think about the suffering that that patient's going through, not knowing where the next stage in their care is. And then there's some other really unique things about the program that they've built that I think together we should be very proud of. We built this on a very unique model that we built a building at the same time. So the opportunity to do that work in a new space so that we could co-locate all of the services a patient would need for musculoskeletal disease really under one roof was very unique. And the opportunity for that for the patient to not be ping-ponged all over the city to get the necessary services and to be able to move care forward was something that I think that we have a lot to be proud of. The other thing is this team is, I would say, really scientific and advanced in their approach to how you counsel patients as far as including patients in decision-making. So they have built more and more robust and scientific models of shared decision-making. And what we've learned from this is that a certain percentage of patients don't want to have surgery. They want to employ other techniques to take care of their disease processes, to remain in their community and remain in their families. And they've been able to leverage philanthropy in order to study their model compared to a traditional model. And so we'll be waiting for that work to come out. Talked a little bit to you about the complex gynecology clinic. You know, the credit, I think, really goes to Central Health. These are conditions that most women don't even want to talk about. Most communities don't actually recognize or treat these patients. But somehow, I think we were able to partner with you to understand that we had a lot of women in our community, especially in our underserved community, that didn't have access to these resources. Actually, some of these diseases nobody had access to, but especially our underserved population really didn't. So last year we provided care to, it'll be close to 5,000 when the year ends, or when our year end comes in September, more than 10,000 patient visits. And over, since its inception, we've provided care to over 10,000 women, or we will have when September comes around. These conditions are really unique. George told a patient story, so I'll tell a patient story. I think Kevin probably has to go hide on this one, but I always tease him that he gets to talk about MSK more than I do, because people like to talk about knees more than our body parts. But about 6 weeks ago, I had a patient. I do provide care in this environment, and I had a nurse practitioner called me. She said, "Dr. Young, you're not going to believe this. We have a patient based on her dermatologic illness that her vagina is fused except for a pinpoint hole. And so she basically urinates into her vagina and then dribbles out all day long." And we were able to see that patient and get her in the operating room within a week, address her problem. But the unique part of the story isn't about the surgical fix. It's about the fact that we work closely with a vulvar dermatologist right there at my side. I'm the surgeon, and we work with a primary care team at People's Community Clinic, where she was referred from, to treat her underlying disease to prevent this from happening again. Oh, and by the way, she has it in her gums, she has it in her hair, she has it on her skins. So it's not just the vagina that was fixed, but because we have this clinic, we're able to, in totality, take care of this particular lady. That's something, if I couldn't have been able to get the folks at Central Health to work with us on, we would not be able to provide those services in our community. And this is another place where I think we should be exceptionally proud of the work that we've done together. talked about that a little bit. I'll talk to you a little bit about the opiate work in just a minute, and I'll talk to you a little bit about the expansion of maternal fetal medicine services that George has not only carried on, but accelerated. You know, when you think about maternal mortality, which has been a big issue in Texas, the majority of patients that die, mothers that die, don't die in labor and don't die in that sort of immediate postpartum period. The majority die in the last 2/3 of the year. If you look at the number 1, 2, and 3 causes of death in Texas, they are suicide, overdose, and homicide. That's what's actually killing our mothers in Texas. So a component of that has to do with opioids. Even one exposure to an opioid results in a substantial percentage of folks with opiate use disorder. And those things are related. So with evolution of pain management and the evolution of what we call multimodal pain therapy, we had the opportunity to intervene with our partners at Ascension Seton, our anesthesia colleagues, to change the way that we prescribe opiates for patients. So not only has this affected our patients here that we share with you at Central Health, it's affected actually all women that deliver in Ascension facilities here in Central Texas. And moreover, it's informed actually the Ascension sort of national standard for how they address care. So this is just a tiny example of something that we worked on as a project that's had really dramatic impact, not only in this region, but farther, with the ultimate goal that just maybe we can prevent some of those deaths later on by having this intervention. Oh, and by the way, pain didn't actually go up because that wouldn't be right. You know, the pain score stayed the same, but the amount of opiates actually went down. And then if you think about a gap, you know, so I talked about glue and I talked about gaps. When you think about those puzzle pieces or those gears that we have to put together, we've had a 10-fold increase in antenatal and maternal fetal medicine visits for our patient population from 2016 to 2022. And that's our patient population. It's the underserved patients. Women really didn't have access to these services, the kinds of services that George provides, for example, at Southeast Health and Wellness. It's an opportunity to provide access to a higher level of care and also to a higher level of services, specifically in the realm of ultrasound. In gastroenterology, in a similar project to MSK, we essentially worked a wait list. When I say working a wait list, you learn a lot about the patients and a lot about the disease and about what we need to do when we develop new care models. But essentially, we were able to provide a lot of services through e-consultation with the providers and not require patients to be on a wait list and wait for a long period of time unnecessarily, allowed them to go to work, but more importantly, relieve them of that burden and that concern that they had something the matter when in fact they really didn't. And I'm most excited about the work that we're doing right now in partnership with Central Health. These pictures are from about 6 weeks ago. They're a group of our experts. In the bottom left, you can see the head of our GI division and neurology in that picture. We're working with you on the physical plant, and you can't build a physical plant without actually having an understanding of what the operational underpinning is of specialty care. So we're working hand in hand with your folks in the build out in Rosewood, Zaragoza to make sure that we have the optimal environment in that clinic space to provide subspecialty services in these areas. And the other thing is we brought our operational expertise, both mine and then my colleague Lisa Jackson's there, so that we're able to talk about what's the most efficient and best way to provide services. Even this morning, we're working on our future clinical opportunities. There's things that we can provide based on the infrastructure that we've already built within UT Health Austin, either in the clinic space or in the ambulatory surgery center. We are working on a relationship to be able to provide long COVID services, advanced imaging services, sterilizations, which is particularly important given the relationships that we have in our community, ophthalmologic services, both inpatient and outpatient, and a place in our ambulatory surgery center so that the podiatrist can work and can take care of our patients. And then we're working also long-term on a professional services relationship. And part of this work, I call it not very sexy work because it's contractual work, but we're trying to develop the underpinnings to make us work together more and more in the future, but also in a more agile way so that we can develop and grow subspecialty expertise for our community and our populations. And, we've been hard at work on that for several months. I think those are coming back to me tomorrow, and we'll try and see if we can move them forward as quickly as possible. So sort of in summary, I feel really privileged that I've had the opportunity to work with you guys collaboratively over the last 7 years. I'm excited about the future work that we can do together. And now that we've got these identified strategic priorities, we really know the map that we need to work on together. We have addressed and will continue to address and prioritize public health issues. I think our COVID work is a fantastic success, and we really need to sort of seize the day and keep this work going. We will continue to support communities disproportionately affected by COVID-19. We did that in the past and continue to do that now. I think health equity is a very big focus of ours. The fact that we share Jewel, and we've already talked about that, is really important. But once we know that programs are successful and sustainable, we need to scale those programs and make sure that we're reaching everybody with the highest quality of care that we possibly can. And then we're working through these sort of contractual relationships to make sure that we can do it more efficiently and so that we can provide more care and better care. So thank you guys so much for your attention, and I'll turn it back over to George.
Yeah, let me just close this out really quickly. Thank you again for having us today. I hope this gives you a bit of a broader view of the things that we've been working on at Dell Medical School for the last number of years and the progress that we have made. I would add that I do know that there is going to be an audit, and I want to make sure that you know that we are willing partners in that and are committed to honesty and transparency as part of that process. I don't know much beyond that, but just know that we're absolutely willing partners. And lastly, I would say that you're an incredibly important partner to us, and I hope that you see us in the same vein. And the more that we know each other, and the more that you understand what we're doing and we understand what you're doing, the better. And Charles, I'd like to invite the board to come to Dell Med and to visit us at some point in the future if you'd like. We'd love to have you for an afternoon. You can actually meet some of the docs that we talked about today doing some incredible work, and some of our other healthcare providers. And Charles, maybe I'll reach out to you in the next couple of weeks and see if we can think about something for the fall. But thank you again, everyone. Thank you for putting up with us talking for the past 50 minutes or so. And if there are any questions, we'd be happy to answer them.
Thank you very much. And George and Amy, I really appreciate the time that you provided us here today. I know I've been on the board now for 5 years, and I think this is probably one of the most comprehensive presentations I've seen from UT in my tenure here. And I thank you for that. I definitely feel that there is such a great value being a citizen of Austin to have a medical school here and to have all of those services available to the entire community. I think it's definitely something that elevates Austin to the point of truly being able to access and have the ability to take advantage of some of the great medical advances out there. So thank you very much. I really appreciate it. What I'll do now is to go around the room for the board members to ask their questions and provide comments with regard to the information that you provided us today. But thank you again. I really appreciate it. Manager Brunson.
So Dell Medical School does provide a tremendous benefit with Travis County and surrounding counties. And as outlined in your slide, the affiliation agreement funds $25 million a year for Dell Medical School. Oh, sorry. Yes, for the Dell Medical School, and $5 million a year for faculty recruitment, while $35 million per year is provided by Central Health Community Care to fund activities that are outlined in the affiliation agreement. So the Central Health Board of Managers' responsibility is to account for the activities paid for by the $35 million, especially those activities that further the mission of the CCC and Central Health as it pertains to healthcare services provided to the population that we specifically serve. So could you summarize? And I have a lot of questions after this, so so you can make this as short or as long because a lot of my questions revolve around this, but could you summarize how does the work described further the mission of Central Health to provide healthcare services to our low-income residents of Travis County?
I'll give it a crack. Big question. I would say that a majority of what you heard today is really about optimizing what we can do for the care of the poor here in Travis County. So almost all of the clinical programs that I talked about and that Amy talked about have a significant focus in that area. Likewise, I do view our educational programs, especially our graduate medical education programs, much more so than our medical student programs, as being not extenders, but other physicians who are really engaged in the care of the poor. So I would say a vast majority of what you heard today, is ultimately focused in that area.
Well, perhaps, but the detail really is not there. And I noticed that you say indigent patients combined with Medicaid and Medicare in your descriptions. And of course, Medicare is not part of our purview. And so we're really, really interested in the indigent care alone. And I'm sure you could slice and dice that out for us so we could get more exact ideas. I would also want to know more about what are the subspecialties that your graduating students go into. And when you say that a percentage of them stay in Austin, what are the specialties they go into where they stay in Austin? Because staying in Texas is great, but we are an Austin, Travis County based funder. And so that is of course of the most interest to me. And then these hours that you give us, can you in any way not just break down the specialties that represent all of the hours that you have quoted here to us, but also how many of those hours are spent in our different facilities? How many hours are spent in the community care clinics themselves? How many hours are spent in indigent care within the hospital system, so that we could really get a better idea of reporting where our $35 million is going for the community. And and a lot of my questions sort of are in that same vein. You give us large swaths, which is very nice and interesting, but what we really need to know is a lot more detailed work. And that's what I'm hoping you guys will either tell me tonight or present to me either by email or in another meeting, the answers to some of these questions that we may raise.
So I wanted to answer one of your questions because it was all I could do not to jump up when George was presenting, but I held my place. And that is when you think about the growth that we've had in GME, one of the things I want to point out is that one of the biggest areas of growth, not only is it in new programs and specialty programs, because the existing programs here really weren't those, but it's also a big growth in fellowship programs. So what you're seeing is, as we grow these new fellowship programs, we are growing now specialists and subspecialists to stay here, because residents and medical students oftentimes will stay in a place where they train. So by providing that training in this space, then we will be able to retain those folks in our environment.
Well, that's great, because that's what I want to know. I want to know the numbers of these people that you have so far graduated out of your programs, have stayed in Austin, and what specialties do they represent?
Yeah, so the percent is 41% stay in Travis County. We can get the information about what the specialties are. It's a mix, I can tell you that.
Yes.
But we can certainly do that, and probably get some information about their practice location in sort of a big picture.
That would be lovely.
Yeah, and I think the the other questions that are getting into the granularity of the hours and the visits, we may be able to do some of that. It might not be quite as granular as you might like, because some of that's going to be impossible to figure out, but we can try.
Yes.
Thank you, Manager Brinson. And as I call on other members, if your question has been asked or if you feel like it's already been addressed, please don't repeat it. So that we won't bore them and so that we won't spend a whole lot of time repeating the same questions. Manager Zuniga. You need to turn your mic on.
I'm part of Tim's work with him on his global health initiatives. And I know one of the things that they just talked about, just funded, was to a joint research project with Mexico, Puebla, and Austin to improve palliative care in the Mexican immigrant population. So there's great research going on with Tim. And he's taking me to Mexico. So thank you, School of Medicine. I'll report it. And then and I also want to make sure that when you talk about the great work that we did with COVID-19 response, it would be nice to have the School of Nursing also acknowledged in that work, since we gave so many shots and filled so many vials. I was wondering about the charity care policy for UT Health Austin and how many, what is provided inside of that. And if all Travis County residents are those below the 200% FPL are included in that policy.
Yeah. So our charity care policy is posted publicly on the UT Health Austin website. So you're free to download it and read it. It applies to individuals that are Texas residents that are 200% below the poverty limit. So for a family of four, about 55,000, and for a single person, about 15,000. I looked at sort of the distribution today. So all of the services that we provide at UT Health Austin, whether it's an outpatient clinic or access to the ambulatory surgery center, it's actually a pretty broad swath of services that have been that people have taken advantage of through the charity care policy at this point. It's I would say there's things about it, the proof of residency and things like that are part of the standard aspects of the charity care policy. I don't know if I answered all your questions around it.
Yeah, that sounds great. And you've reported it for a lot of your numbers, but for one of them was the surgeries performed at the ambulatory care. I didn't see you did it for MSK for sure, or MKS care. But how many of those were MAP or Travis County? Probably too much of a too granular of a number.
So we're not there, and we're all starting up. So part of the ambulatory surgery center, the complexity is actually going through sort of this contracting process to provide services. And that's actually one of the things that we've been working on with Central Health, and we're working on actually this morning. But the kinds of services we provide, you have to crawl before you walk. And so you have to, essentially we started with a couple of services. We didn't add MSK until later because we wanted to make sure that we could provide safe care and efficient care and that. And then we've also been working, to bring on different insurers as we've been moving along.
Great.
And I think if I didn't acknowledge the nursing school, I don't know what I would do without Stephanie.
Stephanie's the best.
So she was part of our consortium. We created this consortium. That's another story for another day, but it's been, I would be there at 6 a.m. in the morning drawing up vaccine. So.
And that's all my questions.
Thank you, Manager Zuniga. Manager Valadez.
Okay, thank you. Thank you for being here, and thank you for being for your presentation. I really appreciate it. But again, I'm interested in those granular numbers with respect to our population, because we're here specifically to provide services and hospital and medical services our indigent care, indigent, most vulnerable, needy, uninsured population in Travis County, which is the 200% FPL limitation. So with respect to that, I'm going to ask my personal question first, and then I'm going to go to what I have.
Many
Never-
of them have already been asked, but go ahead.
Okay, well, I guess I'll do ours first. On pages 27 and 30, which are going to be the ones where you talk about the musculoskeletal. The Musculoskeletal Institute and Women's Health Institute. How many of those totals were MAP, specifically MAP, where Travis County residents receiving charity care financial assistance? And I know, thank you, Ann. And I do know that here it says it's 2540 patients in the Musculoskeletal Institute, and it was 1,105 patients served by the Women's Health Institute. So if it's possible, I know you're not carrying figures around in your back pocket. If it's possible for you to get those get that information and provide that data to Mike so that he can provide it to our board or to Dr. Bell, so that we can have all that information with respect to that, unless you happen to know it. But specifically for MAP and Travis County Charity Care eligible.
I don't know those numbers right off the top of my head. And I wouldn't want to give you inaccurate information.
Correct.
We do have the ability to tease it out. So just let me clarify the question though. The question is, what percentage of these patients were MAP?
As
And
the number, not percentage.
Okay,
the
the number
number.
of patients that were MAP
That's
and the
correct.
number of patients that received charity care services?
That's by both the Musculoskeletal Institute and the Women's Healthcare
Okay,
Institute.
we can tease that out.
Okay, and then on page 19, which is going to be where you talk about benefiting all Travis County residents, care provided by Dell Medical faculty. This page, that slide. It said you had 280,000 plus hours of care in the community each year, not including the UT Health Austin clinics, not including them. How much of that percentage of their salaries are attributed or included in that 35 million that you're receiving from our taxpayers?
Yeah.
That's going to be another number to
Yeah.
tease out. And since these are already pre-typed, I'm sure we can give you copies of them so that you will be able to provide that information to us.
That would be great.
No problem. And then here's another one. Since we, like I said, we are representing the indigent and most vulnerable Travis County residents that are under the 200% FPL, I'd like to know exactly how much of that 35 million is being spent specifically on that population, what services are being provided, and where would you have those records so that we could inspect them? Because as you know, as UT well knows, they keep records of everything. Everybody knows, your nonprofit corporation knows exactly how your money is spent. So since we're giving you that money, we're providing that money. We're not giving it to you, we're providing that money for services that are supposed to be provided to our population. Then where is it that we can go and inspect those numbers, and where are the reports that you could be providing to us and will you provide to us in the future so that we can build upon a relationship that does speak to transparency and openness, because there's so much that we can be doing together to solve the problems of Travis County and Central Texas. With respect to COVID, over 50% of the deaths were Latinos. Yet I didn't see a lot of activity in the poverty Latino population. And we brought that up to our Central Health Board. If it had not been for Central Health and Community Care, there would not have been as immediate as a response to that COVID disaster as occurred. And I also have to thank the Austin Latino Coalition for drawing attention to the fact that the disparity and that gap did exist, because it was not being handled by other entities that were specifically created to provide that service. So I want to give kudos to us for having stepped up, and to the Austin Latino Coalition for drawing attention to that gap. And, this is another place where you could be partnering with already existing organizations in our community that have a history of service over decades of participation and reaching out to those people and to those places that may be unknown to y'all. And so I hope that you would help our population and help Central Health in reaching out to those so that we can build those partnerships that work and not have this problem when another virus hits us or a virus mutates and leaves us all in the lurch with another over 50% of our Latino and minority population dying as a result. It's not that they were hit and survived. No, they died. So this is life-saving service that we can hopefully count on y'all to help us with. And would you be amenable to that?
Yeah, I would say from the data that you asked for, we can do our best. There's going to be an audit, so I would imagine that some of this will come out in the audit as well. So that should be sort of helpful.
Yes, sir.
And then,
well, we're gonna have the audit. I don't know that UT is gonna have an audit. So that, I think that's a distinction. If all our partners are being called into play, then that would be all our partners. I would hope so. But I would also hope that in attempting to reach that partnership and that transparency between us and that relationship building movement, that y'all would be willing to provide those regular reports to our staff and to our board, and that we would not have to be begging you to provide that or having the public ask for that information, because we can do much more together and we all have the same common goals. So I really hope that you don't recognize this or assume that this is a critical comment that I'm making, rather a constructive comment, because I support and wish y'all had existed long before you got here. Then I wouldn't have had to go to Baylor or Scott and White for my daughter's services. But I hope you all improve upon the numbers. I hope you look to building equity even in the numbers of residents that you attract here, because I look at the demographics for the state of Texas. You represent our flagship university, and we need a hell of a lot more minority residents than you are providing. And I'd like to see the same reflected in your staff, in your tenured staff, and in your administration. Thank you very much.
Thank you, Manager Valdez. Any comments, follow-up comments?
no, maybe Charles, maybe you and I could do some work on some of those questions offline.
Oh, definitely. Definitely.
Thank you.
Manager Greenberg?
Yes, thank you very much. And thank you for the presentation. I do concur with our chair, Bell, that this was more comprehensive than we've seen in the past, and I appreciate that. And certainly appreciate the work that you've done with women's health and musculoskeletal and other for our underserved population here in Travis County. So thank you very much. And thank you for being with us this evening. I know that you have many demands on your time, so we appreciate that. As some of you know, I have a background in finance and budget. And I think that both qualitative and quantitative data are both very important. We are about caring for people, and we always have to keep that in mind. In our population, those who are under 200% of federal poverty level. So hearing those compelling stories and seeing the presentation is really helpful. But we also need that quantitative data. And you had a budget overview. I think that was there was a budget overview of allocation of funds. I think that was on page 11. Can you outline which of those line items or what portion of those line items are specifically directed at the population served by Central Health, which is, of course, Travis County residents under 200% of the federal poverty level? Because again, we have a specific obligation as an entity, as a unit of local government, to be serving patients under 200% of the federal poverty level. So really need to know, the proportion that is directed at our population, not just the kind of overview allocation of the funds, but that granular look at those line items and what portion of each is serving our population that's under 200% of the federal poverty level.
Yeah, Manager Greenberg, maybe I'll take a crack at that. I think your question is very similar to Manager Valadez's question.
It is. Mhm.
So I think this will be some work for us to do offline, but I hear both of your questions.
Okay, wonderful. And then again, in the budget overview slide on page 11, what expense categories are included in the clinical overhead line item? And
So
I don't expect you to have that off the top of your head, but again, I would like to get that detail. And I would ask that, you know, we can provide these to you in writing, but then that you provide all of this information back to our chair and to our staff so that it can be disseminated. But really need to know in that, again, in that budget overview line, what expense categories are included in the clinical overhead line item.
We can do that.
Okay. Excuse me. And then my last question is, again, is it possible to outline the budgeted expenditures for the 35 million received from Central Health and CCC in a line item budget format? As someone who has spent a lot of my life producing and analyzing budgets, you know, we really need that line item format to be able to discern what's going on as far as the revenues and expenditures for our population that's under the 200% of the federal poverty level. And I would also, you know, this would delineate, as I said, the dollars allocated to healthcare delivery versus administration, right? Because again, in looking at the line items, we really need to be able to parse out what is healthcare delivery for our population under 200% of the federal poverty level versus administration. And also any clinical services that are provided with that 35 million at a claims equivalent level of detail. Would like to have that level again, because what we need to know is the services that are being provided to our clients who we have the privilege of serving and who desperately need this health care and help, who are under 200%. So any clinical services provided with the 35 million at a claims equivalent level of detail, when possible, would be appreciated.
Sherry, can I speak to that for just 1 second? So the agreement that we have is it's actually built on a bundle that I talked about earlier, so it won't look the same way that has in the past. And so we'll try to do our best around that.
I understand, and I deeply appreciate that. And then my final ask would be, in the future, when you're providing updates to us and to the community, I'd like to see this information in the future provided in this way, with this line item detail for the population who we serve, this budget information provided at the line item detail for the population we serve, which is below 200% of the federal poverty level. Thank you so much.
Thank you, Manager Greenberg. Any follow-up? Manager Jones?
First of all, thanks very much for the opportunity to join us here today. I've been on the board going to my 5th year now. And my questions relate to more of a philosophical approach in terms of how Central Health and the funding for UT has come about. Many of the questions my colleagues have asked, from someone who's familiar with administration, I don't understand why we have not had them asked before. We have provided $35 million or so every year to support this institution. Concerns I have is that the taxpayers every year have to pay their taxes in order to sustain their ability. We have made a commitment to provide for those who are 200% of poverty or below. And so it would be interesting how much money we've invested, how much of clients we have seen in the development of that. So consistent with the question that was asked by my previous manager, can we get a matrix on a routine basis of the number of clients that are seen? You had part of it in your presentation that can be reported out on an annual basis so that we can be able to go back to our commissioners and our other representatives that we represent the community to tell them what they are getting for the money and who's getting them and how much. That's one thing. So I would encourage us to see us, meaning us, Central Health, as well as you all, work together to develop something that can be proactive in sharing this information. Why it has not happened and we haven't been able floors me, but that's water under the bridge. I'd like to go for us to consider a mechanism to do that. So that's a question to you, Mr. Gieslam, in working to see how we can develop that. The second thing I want to talk about is diversity of the population. I think my colleague, Manager Valadez, talked a little bit about particularly the impact it has had on services in the Hispanic community. In the African-American community, what I'd like to see particularly is your class recruit. How many people are in your school, in medical school? Where are you recruiting them from? And how has that represented itself in terms of physicians that are in our community now over the time that you've been here? That would be very helpful to be able to say it. We have enhanced the number of African-American physicians in this Central Texas community, or in Austin, Travis County particularly, over the last several years. And particularly, I'm interested in what impact in terms of new facilities, new clinics, new cooperation you have with other players that focus in on the 200% apartment. So do you work with Peoples and some of the other clinics as well? When I had the opportunity to live in Houston, a medical school there, worked very closely and engaged with preparing, recruiting folks from those communities. My question is, can we, one, not just say we're doing it, but can we demonstrate it in the data and provide that in the data so that we can reflect to the community, this is what we're seeing there. So basically, most of my questions related to, I'd like to have some data that I can handle and share with the public so that we can say that we're doing this and show that we're doing it and not just say, this is what we're going to do, this is what we'd like to do, but this is what we have done as well. A couple other questions. One is, prior to the establishment, and this one you may have asked, the Dell Medical School, UT Southwest faculty and residents provided services to the population served by Central Health. Are UT Health Austin faculty and residents offering the same number of clinical visits to MAP, charity care, and Travis County uninsured patients as UT Southwestern faculty and residents provided prior to the transition? That's a question we can ask for another time, and if the answer is yes, are there data that can justify and support that?
Can I take that?
Sure, please.
So we've showed you some data that we're providing many more services and we have many more residents than we did before. So the question that was asked by Ms. Valdez is if we can get to that level of granularity, we may know that. The other thing that we would have to see if we can do is find out of those folks that stayed in the community, we gave you sort of the total numbers, is if we could get the demographics of those folks that stayed in. So we'll have to look and see what we can get there.
Yeah, and I would add, I think one of your questions, Manager Jones, was around underrepresented minority students who go on to stay in Texas. You were still pretty young, as students who have graduated. So we are going to be tracking what our students do and where they end up. Our first graduates haven't even completed their training yet. Like our first medical students are residents right now, and then we'll probably finish in the next couple of years. And then, but yes, that will be information that we will be able to provide on an ongoing basis.
Proactively as opposed to reactively, because we do know that they are not finished, but when they come out, it would be helpful for us to know that so that we can go back and share with the community.
The piece we would know is the trainees that have been under our watch that stayed in the area, we should be able to get that information.
And what about those that have come from the Austin, Travis County area? Would you be able to identify those? Those who lived, who came out of Austin and Travis County? Local, yes.
Maybe. I mean,
Okay.
it depends on how they, maybe.
Okay.
I can't say for sure, but maybe.
Okay. And the last comment I want to make is that part of this discussion is part of a bigger discussion we at Central Health is having. We are a unique health, should I say, a unique hospital district. You look around Texas, we are probably most unique. And the model that we have lends itself to be able to finance a medical school or help to finance a medical school. We also need to look at how we provide services in a variety of ways. So as we go through the development of whatever model we ultimately end up in, it'd be very helpful if a medical school could give us insight and input in terms of what you think would contribute to making the medical school better as we develop different models we looked at. Okay, thank you.
Yep,
Thank you, Manager Jones. Manager Musaitif.
Very sensitive. Well, thank you so much for your presentation, for being here, and I echo our chair. It was really one of the most comprehensive presentations we have had from the past. Now, if you remember me, I've been here since the development of the medical school, and I attended your first inaugural talk at the Wildflower Center a few years back. And I specifically remember the passion that you had during that time. And you've actually delivered on what you've promised. And I commend you on all the effort that you have done. And I certainly believe Travis County is healthier because of Dell Med. And especially we've witnessed it through the pandemic. And I do not know and cannot fathom how we would have combated the pandemic without Dell Med and the expertise that you bring to the table. With that said, I know I've met several of your faculty members, and the reason why they came to Austin is because of our mission to provide care for low-income, underserved population. And every single person that I met, that is what drove them to Dell Med and to serve this community. With that, I'm curious to know how many of your doctors are practicing at community care, and how many have you been able to attract to serve our population at our FQHCs? I'm not sure if you have that number or not.
So you're asking, sorry, how many of the people that we've recruited work in community care? I think it's actually one of George's slides. Or are you asking how many of our medical students go on to work at community care? Because that's probably a little early for us right now.
How many faculty have you recruited that work at community care?
Yeah, I think
I didn't see a number.
Community care specifically, I think our number is 65% of our docs are involved in the care of the underserved directly. Now, that doesn't mean that they go to community care, though. They could be at Lone Star. They could be at other People's.
So they're within the Travis County. Okay. Now, and you've shared very powerful stories, and I think people's stories are very powerful. And to really communicate, I think you share with data, but the story can be very impactful in what you do on a day-to-day basis. And thank you for that. I believe some of the questions that are that we're sharing with that you've had a copy of that and that we're asking you. One of the questions that our board is asking you, as Central Health begins to purchase healthcare services, will the Central Health contribution of the $35 million be considered when developing the rates you charge Central Health for clinical services contracts with UT Health Austin?
So I can answer that question because that's the work that I've been doing primarily with my team. And so in general, we really don't have market power given our small footprint to really affect a lot of market rates basically within our community. And so there's a lot of other, I would say, factors that influence rates. Part of what influences rates is actually cost as well. And so we take those things into account. You know, we have a unique affiliation with you. You take care, or we take care of together a population that we want to take care of jointly. And so all of that is taken into consideration when we provide services for the central health population. I would also say that, you know, to the best of my ability to see, the total cost of care in the programs that we share together right now isn't covered by the remuneration that's given to provide services for our patient. Part of that has to do with we're a startup, small, lots of overhead that's associated with starting stuff from scratch and from the ground up. But we do take that into account specifically when we are talking about contracts for specific populations.
Now, I know there was a department within Dell Med, like initially they were not taking math patients because of contracting. And I'm hoping in the future this will not happen, and the expansion of services, like whatever service you provide that is at Dell Med that is open and available to all patients, especially our population. So that's really a hope and a call. And I hope that you can expand the oncology services that you have, and also in terms of the population cancer survivorship, especially our patients who experience multiple chronic illnesses. But whatever, I'm hoping that whatever service that you provide is accessible. And in the past, it may have not been due to contractual issues. And the last comment that I have is, if you ever have an opportunity to conduct a economic study regarding the impact of the Dell Med School on the population that we serve, we are interested in a few items that to be accounted for, such as the value expressed in dollars the medical school brings to the population of Central Health, the economic return for the families with low incomes being served by the medical school, and lastly, comparison of the investment cost and value of the medical school to the safety net in Austin, Travis County, where the hospital district invests in the medical school, to the cost and value of the medical school to the safety net in another city, county in which the hospital district does not contribute to the medical school. So these are some of the issues that things that we would like to see in your economic impact if you ever have a study in the future.
Yeah, the President Hartzell, president of UT, has talked about an economic study of Dell Med, and we will communicate those questions.
Thank you, appreciate it, and thank you for your time and for your service to our community.
I wanted to make a comment on your comment. And
Yes.
so we very much would like to partner to grow access to services that we currently provide. And I've been working with your team for the last 6 months to try to accelerate that process and create new models so that we can do that much more agilely and faster. So we look forward to that opportunity.
Thank you.
Thank you, Manager Musaitu. Manager Zamora?
No questions, just a selfish request.
Thank you.
I'm Pete Zamora, grad practice here in East Austin, been the past chair of the board and past president of TCMS.
Microphone, please.
Past president of TCMS as well. I don't think either one of you all got to meet our great CEO, Lou Goodman, before he passed. When I was chair, he called me into his office and asked for one special request that I continue to request every time we meet. Back in the 90s, this is gray hair, lots of history. Back in the 90s, my alma mater, UTMB, was infringing on some of the other private physicians, and there was a big fight. And he didn't ever want to see that ever again, because he was part of that. He was trying to be amicable with both sides. So his request to me was, or his charge to me was to ask you guys as the Dell to work amicably with the local physicians. I like the work you guys do with TCMS. I like this last weekend's introduction of the students to all the private physicians in town. And let's keep doing that, because this is the way we should do. We need to all work together for the betterment of the county and the city. I thank you for your work. and thank you for being here. If you need anything, call me. You've got my number. I'm part of your population health department.
Great, thank you. Thank you so much.
Thank you, Manager Zamora. Manager Motwani.
Thank y'all so much for being here, everyone, all of y'all. And really would just like to echo, Manager Musaitiv's preamble expressing gratitude for the value add that's quantifiable and unquantifiable in so many ways for our community of the med school. And early successes as well in fulfilling on a lot of the promises. I also want to envelop that with, I think, what is pretty consistent ask of each of the managers, from each of the managers, around, of course, more granular detail on dollar cost. I think a reasonable person might not expect that there would be a one-to-one dollar to care sort of relationship, 35 million, but just starting with some number allows us to explore that daylight and maybe again explore, as Manager Greenberg was sharing, more around the qualitative side and begin to assign a benefit cost to the overall value and quality that the med school is providing that may not be dollar quantifiable. And then of course that might feed into the notion of an economic study to see what that ROI is, but that enables all of us as stewards and investors and stakeholders and patients to be able to, I think, get a better assessment of the value add. Thank you all so much for being here.
Great. Thank you.
Thank you, Manager Motwani. A very quick comment and question from Manager Greenberg.
Yes, thank you. Just an addendum. And again, thank you for your time and all that you do. And on that cost benefit analysis, yes, not everything is quantifiable. So sometimes we have to find stand-ins, right? When we're doing a cost benefit analysis, it could be looking at how many children have asthma, and so I think, again, this economics study is going to be very important. And then I would be remiss if I did not stay true to my finance self. Several of these questions and numbers that we've asked about, Manager Valadez and myself and others, when we're asking about this granular information and the line item budget, in fact, we've asked about for a few years previously. And so my question is, not just for the year we're looking at, but could you go back? I like to see at least 3 years to be a trend. Could you go back at least 3 years in providing that information?
I would say we can try.
Thank you. Appreciate it so much.
Thank you, Manager Greenberg. Very quick.
5 seconds.
Very quick, Manager Valadez.
Very quickly, our taxpayer contribution to y'all has been about $1 billion. That's a lot of money, $1 billion. And in keeping with what, since Sherry and I were both appointed by the commissioners at the same time, we have asked these questions consistently of your predecessor, Clay Johnson. We did not get any answers. And I am hoping that you will be more open and transparent and creating a foundation of relationship building that will benefit both of us and the community, especially the community at need, which we are both supposed to be providing services. We, by statutory legislative creation, we're doing this by law. And as such, I'm as interested as I am in what you do for population health because it affects us all. Legally, we're here to support the uninsured and the working poor and the under 200%, the indigent, under 200% FPL. And to that end, I hope that you will be open with our CEO, with our chair, and with us as board members to make sure that both the commissioners and the city council members know that their efforts in supporting us is not unfounded. So thank you very much for being here. And I greatly appreciate y'all's honesty, at least to the extent that you can provide it, and your courage for being here, because I promise you there are going to be people out there in the public that have been watching you, and I feel very confident that we can work this out and we can forge a much stronger relationship together. Thank you.
Thank you, Manager Valadez. Again, George, Amy, thank you very much. I look forward to working with you to sort of get some of these questions both clarified and answered. And we can surely meet within the next, few weeks or so. To see how our game plan is to.
Microphone, please.
I'm good, unless it's dead. Okay. To see what our game plan is to address this. And thank you so much.
Great,
I really
thanks.
appreciate
Thank you, everyone. Thank you.
Thank you. I thank this
Thank you
board.
so much. Deeply appreciate it.
Okay, managers, since we've taken probably the majority of what we were going to do in the board meeting, I need to ask for public communication. And so before I put a pause and go back to strategic planning, I would like to ask, take up as our next item of business, public communication. Members of the public who wish to make comments virtually during the public communication portion, right, of the meeting must have registered with Central Health via online forum or by telephone no later than 2:30 p.m. today. Yersinia, did anyone register to make comments for the board meeting?
No, Chairman. We had 2 people signed up, but unfortunately, due to timing, they needed to drop off.
Okay. And did we have anyone that signed up for strategic planning meeting?
We did not.
We did not.
No, correct.
Okay, thank you very much. I appreciate that. I will now, let's see, where am I? Members, we will return from our recess. Yes. Okay. Okay. So I would like to, do I need a motion for that, David? Okay. I need a motion to recess the board meeting.
So moved.
Okay, and do I have a second? I have a second. I have a motion by Manager Mafwani. I have a second by Manager Jones. All in favor?
Aye.
Any
Aye.
opposed? Motion carries. So we will now return to our strategic planning meeting. And our chair will take over from here.
All right, so. All right, so let's see where we are. Beginning, should it be here?
This is just motions.
Oh, here it is. Thank you. Okay. Thank you. All right.
And you don't need to do the public communication.
Right. Okay. We will now proceed to the strategic committee agenda. So first, we need to review and approve the minutes of the June 8th, 2022 meeting of the Strategic Planning Committee. Do I hear a first? Yes, Major Valadez is a first, yes.
I move that the Strategic Planning Committee approve the minutes of the June 8th, 2022 meeting of the Strategic Planning Committee.
And do I have a second? Yes, and Major Dr. Guadalupe Zamora seconded. Thank you. And then we need to discuss and take appropriate action to approve a consultant contract for the next phase of Central Health's ongoing equity-based systems planning work, which
Excuse me.
includes developing operational implementation.
Do we need to vote on the approval of the minutes?
Oh, I'm sorry.
We
Oh,
have the
yes,
second.
yes, I always forget. Okay, so may we have a vote first on the approval of the minutes?
All those in favor say aye.
Aye.
Opposed?
No opposed. It looks like it was agreed upon by all. Okay, so now discuss and take appropriate action to approve a consultant contract for the next phase of Central Health's ongoing equity-based systems planning work, which includes developing operational implementation and financial sustainability plans in support of the board-adopted healthcare equity plan, AKA the Equity Focused Service Delivery Strategic Plan. And Monica Crowley and Belina Bunch will be presenting.
Thank you, Monica Crowley, Central Health, and this is going to be a hybrid presentation because Belina will be presenting virtually, and I'm presenting here today. So, hi, Belina, or hi, Belina. Thank you for joining virtually. Next slide, please. So you are all familiar with this slide. This is something that represents the components of a high functioning system of care. And I think all of you remember that last year, the Central Health Board, you directed staff to take this equity focused approach to assess the safety net healthcare needs for the first time. So a safety net community health needs assessment, gaps and capabilities in our system of care, and working with the community to directly engage the community in telling us what needs that they're experiencing through the voice of the community work. And this was all in service of the development of the Equity Focused Service Delivery Strategic Plan, also known as the Healthcare Equity Plan. And this work was funded last year through a $600,000 grant from the Episcopal Healthcare Foundation in support of the work. Next slide, please. And in February, you adopted this healthcare equity plan based upon the work that was done over the past year and in the previous slide. And you're familiar with how this healthcare equity plan is working to drive our strategic priorities for next year. Next slide, please. And if you remember, there were multiple parts of this equity systems planning work. Is we've completed this first strategic planning part with the plan that you adopted in February. And now we are moving on to the operational implementation planning and financial sustainability planning part of the work. The healthcare equity plan describes the what that Central Health needed to engage in. And then this next phase of operational implementation and financial sustainability planning is going to address the how and when, as well as the sequencing of how we go about achieving the goals laid out in the healthcare equity plan. And in support of this work, Central Health applied for an additional, Central Health applied for an additional grant from, oh wait, so this is not, it's not gonna work. Next slide, please. Sorry. Maybe we can. Central Health applied for an additional grant from the Episcopal Health Foundation to support this next phase of the operational implementation and financial sustainability plan. And the Episcopal Healthcare Foundation did award Central Health an additional $600,000 in support of this work so that we could develop a financially sustainable, comprehensive, and high-functioning safety net system of care in Travis County. And we went out on a procurement process to engage a consultant to help Central Health take on this large body of work that is anticipated to continue over probably the remainder of the summer through the fall and winter, and be completed in late spring of 2023. And on the next slide, Belina is going to describe that procurement process.
Hi, I'm Belina Bunch, Procurement Director for Central Health. The procurement process for the RFP was launched in April of this year to continue on with the phase work one. It was phase two of the strategic planning. We advertised it in all of the local newspapers and platforms that we usually advertise on, including BidSync, which is the nationally known platform that reaches spans past the Austin area. We wanted to try to just include as many people, as many consultants as we could. We also listed a solicitation on the comptroller's website, the ESBD, which is a state website that also reaches a lot of organizations that and vendors that we may not even know about. In addition, we also sent out an email to those vendors, and it was 765 vendors that we emailed outside of the advertised areas and the websites that we advertised on. The solicitation closed on May 5th, and the report on BidSync showed that it was sent to 38,117 vendors. They were notified, and that includes 6,788 hub vendors, which represents about 18% of the total vendors notified. An evaluation committee was comprised of 11 Central Health executives and staff members who are all culturally diverse, with experience working directly with the population, all passionate about this work. There was only one responsive proposal, but it was the best responsive proposal because it was the response to the consultants who actually did all of the groundwork and the field work. And so after the evaluation team scored that proposal, we still went through the process for them to make sure that the deliverables were going to be met, the deliverables that we listed in the RFP, that they were going to be met. They were satisfied with that, and we issued a notice of intent to award to Guidehouse.
Thanks, Belina. So we are proposing tonight the terms that have been described as there is an initial contract term of 1 year with 4 possible renewals. We are not expecting that this work would continue with Guidehouse past this fiscal year 2023. We're anticipating that it would be completed by May or June of 2023. And the contract has been negotiated at an amount not to exceed 907, or the terms proposed are that the contract would be negotiated at an amount not to exceed $975,000, primarily funded through the $600,000 Episcopal Health Foundation, and supplemented by funding that's budgeted in fiscal year 22 and fiscal year 2023 consulting budget priorities. And next slide. And tonight we are requesting that you take action to delegate authority to the president and CEO to negotiate and execute a consulting contract with Guidehouse for this next phase of the equity-based systems planning work to develop the operational implementation and financial sustainability plan in support of the healthcare equity plan.
Belina, do you have anything further to add?
No, ma'am, that's it.
Okay, that's great. All right. So if we could, oh, yes, sir. Yes, sir.
Actually, I have a comment. This item has to be approved by the board, okay? But we do have a majority of board members attending this meeting today. We can move this to be on the consent agenda, and it is on the consent agenda. so that when we go back into the board meeting, we just have to approve the consent agenda. We don't have to bring this up separately. So just want to outline that for you guys. We can discuss it fully in here so that we don't have to rehash it at the board. Thank you, Madam Chair.
Oh, thank you. Yes, yes, Manager Musaitu.
Thank you, Monica, for your presentation. And I'm glad the work is moving forward. That's great news. So the comment that I have, you said 600 of it is from the Episcopal Health Foundation. So from our budget, technically be 375 coming out. Okay, just for clarification. Thank you.
Yes, thank you, Manager Musaitu. Any other? Yes, sir. Yes, Manager Jones.
Actually, I have a couple of questions. The first one is, have we moved the motion on this to vote to send it to the board?
Not yet.
No.
Okay, so
She
should we?
hasn't called for a motion, but I wanted to explain that.
Right. So I guess my question, should we have it moved and then to have the discussion again as opposed to after?
What he's doing is asking for you to ask for a motion and a second, and then open for discussion, and then let them.
All right. So would someone like to move? Yes. No, to make them, to make the motion. Yes.
I'll make.
Yes, thank you, Manager Musaitu.
Just want to make sure. I move that the committee recommend that the board delegate authority to the president and CEO to negotiate and execute a contract for up to $975,000 on the terms identified in the staff presentation, or terms at least as favorable to Central Health as those discussed.
Thank you. Manager Musaitu has moved. Do I have a second?
Second.
And thank you. Manager Matwani has seconded.
So now you open for discussion.
So now it can be up for discussion. Yes, Manager?
Thank you. So the 975 is going to be a continuation. That's a total of over the possible 4-year options. I want to try and understand.
Yes.
We got from 600 is gone. It's being paid for by Episcopal Health. The additional left, the remainder is what we're committing to, but 975 does not add up. So is that going to be for possible options?
We actually take one.
Yes, but 975 is the total amount that we are requesting. That is the total amount. That is the NT of the contract.
Okay, so what I'm asking for is how much of that are we paying for out of our budget?
375.
So then should the resolution, of which should there be a qualifier that stipulates that of which 375 $375,000 is coming out of our budget. I'm just trying to, because if somebody were to read this, they would say, we're going to give you 975 of our dollars. Well, we know it's 600,000 that's coming from Episcopal. What's really coming from us is, unless you're assuming, because it's already been commingled, the 600 with with our budget. So I just wanted to make sure. I wonder if my question is basically, should we have a qualifier that stipulates or not, or just the mere fact that I'm stating this public, it's really 600,000 that's coming from Episcopal Health, and Central Health is only paying for 375 from our taxpayer dollars. Is that what I needed to have done?
Yes.
Okay,
Yes.
so in addition to that, no, I know. In addition to that, I still had another qualifier. Why is it taking it so long? And why was there to actually get any response? And then we didn't. All we got was Guidehouse, one entity to submit a proposal for this. And the reason I'm asking it, and is Guidehouse, I don't think I know their demographics. I would like to know their demographics. I'd like to know. Because we're talking about addressing the root
issues of systemic racism, the effects of that on our entity, our agency, on Central Health. And what I'm reading here is basically how someone speaks to each other in a meeting, according to what I'm seeing here. And I'm curious as to how we're going to get to the root issue of systemic racism in Central Health and address that so that we can eliminate as best possible that which some have construed in our community exists in Central Health. And what is this entity that submitted a proposal going to do to address that? And not necessarily, I mean, how we speak to each other is something we have to take care of, but I'm talking about $975,000 to address an equity issue in Central Health and for the provision of services that's based on systemic racism. And I'd like to know how they have responded to that before I vote on it, because I'm not seeing it. And I'm not trying to be difficult. I just want to understand.
I think that was our original agreement that we made a number of months ago, and we've just are including it in every board packet now. And so that is already between all of us and not.
I think I'm asking the question as to why has it taken so long? What is Guidehouse to fund this? Unless we were always intending to give it to them. And if not, well, why do we only have one entity respond? And why are we giving it to one entity? Should we not actually, in fact, expand the search and see if anybody else responds? I heard what she said, and I do appreciate all the great work y'all have done. And sending this out to, 800,000 people, or entities, or 8,000 entities. But I'm just wondering, what is the problem? I mean, why is nobody responding to something that it affects us so deeply?
Manager Valdez, we did have 48, just to.
Oh, I misunderstood. I'm sorry.
No, I don't think I said this in my.
Well, that would have helped me.
We did have 48 vendors that actually viewed the solicitation. We sent it out to 38,000 vendors. Yes. 48 of them did view it, of which 13 were hub vendors. It just fell down to Guidehouse was the only vendor who sent in.
They were the only vendor that submitted a proposal.
Yes, ma'am.
Well, that answers that, but I appreciate you clarifying it. I just would really like to know. I would like to personally, at something else, maybe you could do it online. I'd like to see what their responses are, because I'm talking about a systemic issue that exists not only in our entity, but everywhere, because that's the nature of the beast, unfortunately. But how are we going to overcome that? And how are we going to make sure that we don't repeat the same historic mistakes that have been made in the past? And so I was hoping that there was some kind of a question that would ask them how they evaluated us to be able to respond in such a way that we will impact our policies and our practices and everything else that affects us at Central Health. Is it possible for us to just get a copy of that, or can someone
briefly explain that to me?
Yes, Mr. Giesler.
I'll attempt to answer some, and some I don't think we ever will be able to answer, because we'd have to speculate what's in the minds of those people that, of those firms that decided not to submit something.
Right, yeah, and we can't respond for that.
I'm going to lay out a couple of points here, and then I'll ask Valina and Monica to fill in with more details to be responsive. But if you go back to what looks like it's page 18 of maybe your committee book, which is it's the one with the eccentric circles that overlap, that shows what the time frame is. The title of it is Equity Focused Delivery Plan. Whenever we first started on this endeavor of building out a high functioning health system that is centered around health equity and eliminating the disease disparities, whether they're caused by systemic racism or happenstance or for whatever reason, and owning up to all of it, owning it too. That's the important thing. Not playing the blame game, but just say, let's just take this and do it. So we've already represented through our voices of the community meetings that we're going to move very, very expeditiously. There's a trade-off there because you move forward on these procurements, and to Belina's point, 48 take a look at it, 13 are hub vendors. You're hoping that you have a really robust submission. But at the end of the day, a lot of consulting firms and individual consultants or consortiums or teams of consultants, they have to make a decision. Are we going to be able, if we put all the time and effort and energy, is there an opportunity for us to get this award? Whereas as a consultant, and I speak from past experience, you can go to a non-competitive environment entity that is not a governmental agency, pick up a phone call, have a few meetings, take some people to coffee, and get another deal that pays you just as much money for a whole lot less work. And I wonder if some of that sits behind it, and that's just the nature of contracting with a governmental agency. At the same time, kind of back to the first point, which is we've made commitments to the community. We're going to proceed with this as expeditiously as possible, as transparently, and get it all out there so everybody can see it. And it is very much part of our imperatives that we have going forward to get these operational plans in place. Otherwise, the health equity plan that identifies all of these systemic racism, and by the way, the operational plans has to square up with the health equity plan that you all adopted. I'll pause there to see if there's anything else I need to add to that, Belina or Monica.
Well, Belina, I don't know how much we can talk about, but this was a public meeting. We did have a meeting where potential respondents participated in, and we had a question and answer with them. And there were questions about whether we would be willing to award this to multiple proposers, whether people could propose to just, do the financial sustainability or some of the operational work. And, we also recorded the questions that were asked and the answers that were provided. And, we did put it out there that we were interested in working with different vendors, even smaller vendors that could, that would
partner together.
Yeah. So
we encourage partnerships all the time on our pre-proposal conferences, and especially for this one, I felt like we needed to encourage it even more because of how large the solicitation package was. When you look at the amount of work that was put in from phase 1, we had to include all of that documentation for a bidder to be successful at even bidding, even if it was just for a portion of phase 2. And I'm literally looking at the questions right now, Monica, that you brought up. There were quite a few questions that vendors asked on the pre-proposal call and during the question answer period that they asked, why are we even looking for another vendor? And if Guidehouse provided all the work the first time, why are we doing this just because of policy? Literally, that's one of the questions. That are we soliciting this because of the policy? And so we did put it out there. We tried to offer it multiple ways, and it just came down to that one vendor.
I appreciate that. Then to the end of approving this.
Microphone, please.
I just had one perspective change, and that was in the beginning statement. And I don't know if it was given to anybody. I gave it to Dr. Bell, but I'll read it to you. I didn't write it, but I can tell you what it was. If Maram, the maker of the motion, and the second will consider this as a substitute motion. And all it says here is, whereas as an organization, right here, I'm going to read from what it says. Central. Can I ask you a question? Yes, sir.
That has to do with the agreements that the board makes with regard to our communication. That doesn't have anything to do. That has to do with the agreements that the board makes on our communication. It has nothing to do with this contract.
Well, I appreciate you saying that because I was kind of confused as to what we were doing here. Okay. So I apologize, but when the motion is made to approve a $975,000 contract, and what I'm given and put in is in front of me is what we've been receiving in our packets all along. I was like, did something change that we had to do this? Well then, sorry, I apologize.
Apology necessary. There's a lot of paper in these documents.
Well,
here,
yeah,
but, what we're asking though is not for you to approve a contract, but to
allow
us
you to
something.
negotiate that.
Because the terms still have to be negotiated, even though the intent.
I appreciate that, Mike. And if we can have an offline conversation about that, because my questions regarding the substance of what was the initial request, the RFP, I still would just like to see. Okay, that's all.
It's public.
Yeah, but I haven't looked for it.
Usually
I didn't.
passes after a period of
That's
time.
why I said if we could have an offline conversation, I could just get that information. I'd appreciate that. Thank you. So
I can send it to Pearl and Brianna. We have it readily available and have them to give it to you.
thank you very much for your great work, regardless of whether only one entity applied.
Yes, two quick questions. One is, who were the member of the executive committees that reviewed this? You mentioned there were 11 members of the executive staff. Could you provide that to us?
Absolutely.
What's the process?
And then secondly is, I had the opportunity to talk with Mr. Giesland and Monica and a few others about discussing the model of a healthcare district that we're interested in. And the suggestion was made that we could incorporate in part of our discussion, part of this equity work, that discussion in some of the community meetings. Is that a fair assessment of what we said? So in the negotiation and the discussion with Guidehouse, if they're indeed the one, would that be part of the discussion?
No, mine? My remembrance of that was that that discussion would be part of our performance review. As we went out to do the performance review.
Microphone, please.
Well, sorry. As we went out and looked at different performance reviews, we go to different areas. You mentioned something about precincts, et cetera, but we were talking about the performance review, not this particular issue. Yeah.
I have the members of the evaluation team pulled up. Would you like that now?
If I may, Alina, I want to make.
Okay, I'm sorry. I didn't hear you talking.
Well, I'm just sitting there thinking about this. It's not all executives, it's executives and staff.
Yeah.
And so just as a reminder to the board, you have one employee, that's me, the CEO. But can I reach out to those staff members to say, are you okay with me disclosing your name to the board? Can I get that courtesy first from them? Because I don't know what their comfort level is.
I have no problems with that, but you all presented that there was 11 executives, I think, that was culturally diverse.
I don't know who all was on the
11 executives and staff, yes.
And staff
Yes.
who were culturally diverse.
Yes.
And my question was, could we see that? That's all I'm asking for. And I understand your concern. I don't know why that would be a concern, but certainly I would have no objection to it.
Sometimes it's a rough and tumble environment that we're in, and staff have expressed some concern from time to time. And I know you have no ill will in your heart whatsoever. You're trying to ensure that we're being diverse and inclusive. And that is but if you'll give me the opportunity to reach out to staff and convince them that this truly is the motive, and they can watch this open meeting here, I think that'll give them some comfort before we push those names out to you. And we'll send them to the whole board.
Or Manager Jones, would you be satisfied if they just gave you the racial makeup of those 11 people?
Let me respond to why I asked that as well.
Just a quick tap.
Okay. The reason is because I don't know, maybe I'm the only one who hears, but I have consistently hear that executives, meaning the leadership, not just you, and Central Health are not diverse. And for us to be saying that as part of our evaluation process, that we use a diverse review of, we use diverse leadership or staff at Central Health as part of our public acclamation would be very problematic, I think. So it would be helpful to say, yes, we did, and here they are. That's all. That's the only point I'm trying to get.
100%, and I wish that. First of all, I don't have the list of those names. Somebody else does, but all I'm asking for is just allow me the opportunity and our staff to reach out and say, hey, they've asked for your name. We're really just trying to ensure that we are being diverse and inclusive and making sure that people with lived experience and perspectives that quite frankly, I don't have are looking at this. And that's part of being anti-racist and having an environment that is inclusive. I think if you'll allow us the opportunity to say as much, get people comfortable with it. And if they say, you know, I'm just not comfortable with my name being out there, because we didn't tell them as part of participating in the review that we were going to publish the names of those that are doing the reviews. And so it gives me an opportunity just to go back and if they decide, you know, I really don't want my name out there, I'll need to come back to you and figure out what to do about it. Is there some other way that can help you identify with, okay, yes, this was truly a diverse, but I would be shocked if most people didn't say, yes, please, by all means, release my name. But I want to go through that courtesy first. Please understand. I'm sorry,
no, I'm fine.
Perhaps I'm being overly protective.
I understand and I respect that. I'm just saying that it would be to make our case a lot easier if we could say that. I would be comfortable if you just gave us a reflection, I mean, a total number by race and ethnicity. That'd be fine too.
And thank you, Manager Jones, because I think what I was trying to express earlier is just, you know, something going to the root cause. And I think that what Manager Jones is speaking to, and I do support him in this, is maybe it's a process issue and how Central Health does RFPs and the whole bidding process or whatever. And when we say, because I have questioned this in the past, when we say that we have a team that has put this together and looked at it, what Manager Jones is speaking to is actually that a root issue, a root cause, or a root. You don't know what someone's lived experience is, and you don't know what someone's thinking in their head. You don't know if they have relationships with other people that are possibly applying for contracts. I mean, we don't know that because we never see that information. But a way to address that generally is to make sure that look at our demographics, as I have asked. Look at our demographics at Central Health. Look at the population that we serve at Central Health. And if the teams, the executive teams, or the teams that are reviewing, the review team, anything, make sure that it's reflective of our demographics, so that at least someone can, Mike, you as our CEO can assure us that a demographically reflective team looked at the development of the RFP or RFQ, reviewed the applicants, and then made a decision or recommendation that would be brought to the board for funding. And I think that would address a lot of issues. I don't know, Manager Jones, I do not know whether that's what you're getting to, but that's a real issue that we have yet to address I think of generally at Central Health.
Thank you, Manager Valdez.
But I would like to know whether or not that.
Yes, thank you, Manager Valdez. And Manager Matwani.
Addressed.
Okay,
Thanks.
thank you. Well, will this discussion prevent anyone from casting their vote on the proposed?
On the only applicant?
Yes, on the only applicant.
I mean, let's call it what it is. Thank you. The only applicant.
You have to, all in favor.
Okay, all in favor?
Aye.
Aye.
Any opposed? No opposed. All right, thank you.
Abstentions?
Motion carries.
Abstentions?
Abstaining?
Oh, abstentions, any abstentions? Manager Jones and Managers Valadez abstained from voting.
But we thank you all.
Yes, thank you. Yes, Manager.
Action.
We're moving the vote, I think, from this.
It's a consent item on the,
David, what she's asking is, of all the people that voted, the members are the only ones whose votes count in the
Correct.
strategic plan.
Yes.
So
And
you want to take the vote again? And they can raise their hand. Well, we need to take it again.
All right, so all those in favor, please raise your hand.
No.
All those in favor? No, that's 3, yes. And all those against? I see no one against and abstaining, 2 abstaining. So we have 3
we have 5
members.
people on the strategic plan? Okay.
Yes, so the motion carries.
Regardless, abstentions never count. It's just a no vote, so it's members present.
So there's 5 people on the strategic planning committee. Yeah.
Thank you. All right, so we'll move on to item number 3. Receive and discuss an update on communications and community engagement activities and initiatives. And this will be presented by Ted Burton and Ivan Davia.
Yvonne.
Oh, Yvonne, sorry.
Good evening. I'm Ted Burton, Vice President of Communications, and my colleague Yvonne Davila, our Director of Communications and Community Engagement. You have heard a lot of information tonight and hopefully digesting some very comprehensive presentations. So I hope this is a late night snack that you can enjoy, and it will be brief, I promise, unless you have lots of questions, and then it won't. But we are going to cover, next slide, please. We are going to cover community engagement activities, both what we've done over the last couple of months since the last time we presented to you and what's upcoming in the next month or so. Talk about a couple of new initiatives, a map marketing initiative and an outreach initiative. And I'm going to briefly cover some social media and earned or media relation highlights. And with that, my esteemed colleague.
Thank you, Ted. So Ivan Davila, Director of Communications and Community Engagement here. So Central Health believes the community needs to be at the center of addressing healthcare inequities. So involving the voice of the community in our work is ongoing and is also the goal of our community engagement function at Central Health. We do this through many tactics and activities, including community conversations. Next slide, please. And next slide. In June, we held 3 community conversations to inform stakeholders, partners, and community members on the healthcare equity plan, including the 3 different assessments that informed this plan and our next steps. 2 of these community conversations were bilingual in Spanish and English, specifically designed using an open house format to engage with community members, including those from our priority populations. The design allowed people to arrive at any time during the workshop and go through the different stations to learn about the healthcare equity plan. One of these took place at Navarro Early College in Rumberg, and the other one at the Southeast Health and Wellness Center. One of the community conversations was held in this room, and this was streamed on Facebook Live, and it was specifically designed to engage with partners and stakeholders, different than the other 2 that I just talked about. In all the community conversations, attendees had the opportunity to ask questions and provide feedback. This feedback will be part of the fiscal year 2022 community engagement report, which will be made available to you and posted online towards the end of the fiscal year. Next slide, please. Similar to the community conversations on the healthcare equity plan, in June, we're holding 3 community conversations on the fiscal year 2023 budget in August. The first 2 will take place in the community, specifically designed to engage with community members, including members of our priority population. You can see the dates on the screen or in your packets. One will take place at the Turner Roberts Recreation Center in Colony Park, and the other one at the Southeast Health and Wellness Center. We're promoting these community conversations using social media, e-marketing tools, and also on-the-ground outreach, including getting help from from parent support specialists at the schools. So help us get the word out, please. You should have received some information on this last week. The community conversation on August 18th is designed to engage with partners and stakeholders and will be taking place here at Central Health. Next slide, please. We also involve the voice of the community in our work through our Community Health Champions program. For those of you who may not know, the Community Health Champions program is an annual program that brings together diverse community members from across Travis County to learn about, discuss, and collaborate on our work to improve the health of Central Texas. On its 7th year, the program is welcoming a total of 38 community members. You can see the demographic breakdown on the screen and also in your packets. We're especially proud of the languages represented in this cohort. Last year was the first time that we offered this program in both Spanish and English. And this year, nearly 50% of our participants are bilingual in English and in Spanish. 34 speak only English and 8 speak only Spanish. And there are other languages represented, including Portuguese, Hindi, Vietnamese, and French. Next slide, please. This year, we took a different approach to promoting the program during our recruitment process, including publishing alumni profiles like the ones you see on the screen. We thank Manager Musaitif and also Manager Matwani for allowing us to highlight your experiences in the program, as well as your work. Next slide, please. Thank you. Through MAP marketing and outreach, our goals are to increase awareness of the medical access program, qualifying people, and get qualifying people closer to getting enrolled in these programs. In October 2021, we began a more intentional targeted approach to our community outreach practices with a specific objective to increase the number of leads generated. Leads are names and phone numbers of qualifying people who could qualify to medical access program, either MAP or MAP Basic. Our outreach partners, which include Community Coalition for Health and Latino Healthcare Forum, conduct much of the grassroots outreach to raise general awareness of these programs. And then they also help us gather leads. They, as you know, focus on high priority communities. They're part of the community and they meet people where they are, like grocery stores, barber shops, gas stations, to inform them of the programs, how to apply, and other initiatives. Once they gather leads, our community outreach specialists take the leads and then they help potentially map eligible individuals navigate the enrollment process. And also connect people to our eligibility department. In terms of results from these efforts from January through April, about 15% of 350 leads were converted to MAP members. We will continue to refine this strategy. Next slide, please. In addition to on-the-ground outreach, we also leverage marketing campaigns using paid advertising to increase awareness of MAP and MAP Basic. As always, we use data from our demographic report to focus on our campaigns on zip codes where people with low income reside. Learning from our campaign last year, we are also implementing a similar strategy as we are with our grassroots campaign, in that we're working toward increasing the number of leads generated through these campaigns. This way, we're generating leads both on the ground through grassroots outreach, as well as online through these campaigns and other paid advertising methods. As always, our campaigns are bilingual in both Spanish and English, and you can see some of the ads that we used last year on the screen. Next slide, please. So what happens when our members enroll? One of our 4 key takeaways during the Voice of the Community work last fall was that members needed more information regarding the services they can access through our programs. So, and we also know that many MAP members don't establish care once they enroll, which could present a barrier once they're actually in need of care. So in collaboration with other departments across the agency, including eligibility, healthcare delivery, and strategy, we are planning an ongoing education and activation campaign to inform existing MAP and MAP Basic members about the services that they can access, how to access these services, and the importance of establishing care once enrolled. This campaign will, of course, take into account current clinical capacity across various service lines, including primary care and specialty care. And as part of the planning phase, we are conducting research that will help us test messaging and will also help us gauge the proper methods of communication. We're considering, of course, both electronic and non-electronic methods so that we can reach members who don't opt into our electronic communications.
Thank you, Yvonne. So I want to briefly touch on some of our social media and digital efforts. Since in June and July, if you follow us on Facebook or Twitter or Instagram or even TikTok, my favorite social media channel, by the way, we published 272 posts in the last couple of months, 90 on Twitter, 112 posts on Facebook, and 70 on Instagram. We don't have TikTok yet because that's an emerging platform for us, but stay tuned. That's my tease. We garnered 661,000 impressions with 9,800 engagements, meaning somebody liked our post, shared our post, commented on our post, which is solid. And the top performing Facebook post of the last couple of months was the one that you see on the screen. It was the groundbreaking event regarding service expansion in Del Valley. And that reached more than really almost 36,000 people. And lastly, moving on to media relations, I'm really excited. Actually, during this meeting, I got word that we have confirmed a date for a press conference in August 16th. The Central Health Equity Policy Council is kicking off its newest initiative, and that is the Healthcare Equality Index, which is a campaign of the Human Rights Campaign. This designation is for healthcare providers that are providing optimal care for LGBTQIA+ patients, and we're very excited about this. This press event will be at the Southeast Health and Wellness Center. We're going to have partners there, participating partners, including Community Care, Integral Care, and People's Community Clinic. People's has actually already obtained this designation. So more information to come on this, and you're the first to see our LGBTQIA+ Central Health logo, which we're very excited about. So you'll see more on this, and we hope that you can join us at the press event. Finally, I want to wrap up with a media relations summary, and you can read this for yourself, so I won't go through it in detail, but our team has been busy writing press releases, distributing press releases, and securing coverage. We've also been conducting what I call desk side visits. So sitting down with reporters and really going in depth. Mike mentioned this earlier. Thank you, Dr. Bell, for participating in a conversation with the Statesman reporter, Nicole Villapiano, and cultivating new relationships. The results of this work, we've had 508 mentions in the media, 968 million impressions, that's million with an M, with an ad equivalency of $15 million. And what that means is if we went out to purchase this type of awareness through advertising, we would spend $15 million. That's not something I made up, although I do like the sound of it, but it is an industry standard calculation that we use. And as I wrap up, I want to say the media coverage in social media isn't by accident. It doesn't just happen. It is strategic, and we carefully consider what messages we're going to push out, mainly messages that we know resonate with our patient population and the people that support and fund Central Health. And you might think, well, gosh, what kind of coverage are we getting? We actually calculate that as well. And more than 90% of the coverage is in fact positive coverage. And again, it's part of our strategy. Tomorrow morning, Mike Geeson will be joining me on our monthly talk show that we host on KZI called Central Health Talks. And Mike and Andrea Shaw, who's also part of the Central Health team. And tomorrow's topic is going to be our health equity plan. So you can't tune in because they're no longer live. We actually tape them, but we can let you know when that show will air. And with that, I'll turn it over to Mike. Thank you for your time. We're happy to answer questions.
And I know that we'd actually planned to do this presentation, but with some of the recent media, let me just provide some overarching comments. As you can see, it's very strategic, it's very deliberate. We don't have to make stuff up. We have great news because of what we do, because of our deeds and our actions. And we're going to continue to push out the positive. But unfortunately, we live in a day and age where running around and casting blame and sensational accusations often passes as progress. And unfortunately, sometimes it's trying to pass off as leadership. But that's not who we are. But that's the world that we live in at times. And so when that does happen, we're going to continue to push out the good news about what we do as part of our mission and the work and those that we serve. And we will, in a very measured way, respond to what it is that needs to be responded to, again, with good news. So we're being proactive and reactive with the work that's done here. We could not be that if it weren't for your leadership in terms of what you all have enabled us to do, and also the great staff that just come to work tirelessly day in and day out to be able to serve people and help people live the healthiest life possible. So that concludes my overarching closing comments, and thank you, Madam Chair, for allowing us to present.
Yes, thank you. Thank you for that very uplifting and very nice presentation. So very exciting. And I think it all lifts our spirits to know that you guys are diligently working, Ted and Yvonne. So thank you very much. And there's no motion necessary for this presentation. Yes, Dr. Ed.
I think this comment is largely because of my appreciation for some of our fellow managers. I know all of our fellow managers are unapologetically relentless in the pursuit of equity in the face of systemic racism. And I mean, I'll uniquely call out managers Valadez, Jones, and Musaitif, who I feel are again persistently making sure that stays on the forefront of the mind, even when it may not be operationally convenient. Which is kind of what the whole thing is about, is that there's been a lot of inconvenience, and so let's sit with some inconvenience. However, we again, as stewards, and have to find that balance of how we can still operationalize what we need to operationalize. And I appreciate that grind point that we find to move forward as a governing group. And we may not be able to win them all, as it were, meaning in this case, in the previous matter, we only one vendor perhaps might have made it through, that wasn't wasn't a minority vendor. And there are probably, or highly probably, many systemic issues that prevent minority vendors that precluded minorities vendors from responding, that we may not have been able to directly have solved for. However, I really appreciate how this organization has multiple facets of how we are trying to solve, or at least mitigate, the challenges of systemic racism. And I think that the Community Health Champions program is, and our general media outreach is reflective of that, obviously. But the Community Health Champions program, and because I participated in it, I like to toot its horn. But I recently went to a recruitment event to talk about experiences in that program, and a third, if not half, of the folks there were Spanish first folks, and a much higher representation than in our community of the participants were African American. And we don't see that in these typical institutional settings very often. And I really, really deeply appreciate seeing that. And I think class after class after class, year after year, we start to amass champions and folks who are naturally involved and integrated, if you will, in our institutional decision making, and have natural incentive alignment to participate. And I think it's a long game thing. And I would just want to point out that there are wins in this area that may not be explicitly where we want to see them, but they all count and they're all part of the bigger picture. So thank you all so much for that.
Thank you, Manager. And so, I'm sorry, Manager Jones.
just have one question. In terms of your location for your community town hall meetings, those that you've had and those that you will be having in August, as I recall, all of them are within the city of Austin's. Have we considered some of the other cities within Travis County, like Pflugerville and Manor and Jonestown,
Yes,
for some of these outreach?
yes, we are. And so as you might recall, I'm gonna just go back a little bit. Before COVID, our plan was to go out into the community and take our community conversations on the road. And this is the first year that we're doing that. And so we wanted to start with looking back at the community health needs assessment, and looking at where people experiencing poverty or people living with low income reside. And so we wanted to start with the obvious, Rumburg, Montopolis, and we're getting a little farther, Colony Park. And so we do want to go to Del Valley and Pflugerville and all of those. So that is the plan, but these are the community conversations that we have set for the budget for August. And so we have 3 that are planned, and as we have more, we will continue to go broader.
I'd like to just add on as well. We say community conversation. I think we think of big, large crowds, but we also have a speakers bureau. We don't have to have a crowd of 100 to present information about our healthcare equity plan or the MAP program. And we have experts, and we are doing this and have done this through our Voice of the Community work, where we're meeting with small groups or patient serving advocacy groups. And it might be 1 or 2 central health employees and 3 or 4 people from the community. And we would love to elicit your support too, because you guys are the faces of the organization. So the community conversations may be the larger group settings, but we also look at these smaller, I might say 101 or 103 or 105 settings as well to present information.
And let me add to that. Thank you so much for that point, Ted, because we have been meeting with Del Valley ISD, parent support specialists or community support liaisons, as they call them. So we do meet with them. They may not be called out as community conversations like you're saying, but we do share this information with them.
Everything you said, I agree with. I'm just saying is that as we look at the gentrification of the city of Austin, what is occurring in these other areas are, as maybe not to the complete degree, but there are pockets of Pflugerville and certainly Manor and parts of other parts of the county that are as bad, if not in greater need. So I'm just saying is that from a public relations point of view, as a Travis County hospital district, I think we need to do a little more to make sure that we're present in doing these same things in these communities outside of Austin. That's all I'm saying.
We agree. We agree.
Well, again,
One last comment, as I have made many times in the past. We have 17 school districts in this county. So it would behoove us to make phone calls to those superintendents and see whether or not they will approve you all going onto their campuses, attending their PTA meetings, or whatever event that they may have where they elicit all their parents and community members to attend. So, they have fairs, they have Jamaikas or whatever.
Thank you, Manager Valdez. And Manager Greenberg?
Yes, thank you. I certainly concur. There, in fact, have been long-standing pockets of very low income in Jonestown and in parts of Oak Hill and other areas, as Manager Jones was mentioning. But I also want to take this opportunity to give a shout out to staff, not just to those who are presenting now, but some of you are still here, I know, virtually, and others who presented tonight and have put in all the hard work for everything that we have seen so far this evening. We deeply appreciate your dedication to Central Health and to the community. And I just wanted to have a chance to say that before the night was over. Thank you.
Yes, thank you. Would anyone else like to say? No, okay, good. So this does not require no motion necessary. So we'll move on to item number 4, receive an update on the Central Health Community Healthcare Initiatives Fund. And it will be Mr. Gieslin and Ms. Bunch will be presenting.
Thank you, Madam Chair. Members, the Central Health Board of Managers developed and put some framework and allocated funds to the Community Health Initiatives Fund. We use the acronym CHIF as shorthand to contract for needed services provided by community groups, nonprofits, and private businesses working to address health inequities among the population that we're privileged to serve. And one of the underlying reasons for this, and I'm just giving you a quick bit of history and getting to why we're coming back to you this evening, is because we realized there were a number of groups that were approaching us asking for funds in the way of grants, but we're not a granting agency, but we do contract. And this body, the board, saw the need to have some funds where we could contract for various health initiatives that complemented our mission in serving our patients below 200% of federal poverty level. And it was a way to capitalize, because a lot of health, as you know, especially with social determinants of health, it happens outside of the four walls of the clinic. And so capitalizing on those community partnerships to provide culturally affirming care and our services, rather, I should say, again, that help with improving the outcome for those that live below 200% of federal poverty level. So that was some of the underlying impetus behind this. And so with that, there was the fund was created. The board provided some guidance on how those funds should be used in contracting. Again, this is not a grant. And so we want to come back this evening just to give you an update about where we are. It's still an open procurement. Please keep that in mind. And so there's some information that we'll probably need to come back with you on as we move through this. But with that, I know I'm at it and have the microphone on. Based on the last conversation, once we do close out this procurement, we'll also circle back around with those members that were part of the evaluation team. Again, I don't know who they were. That's by design. But see if we can get permission to release their names, or at least provide some information to answer the question. I'm assuming that that's, should probably be a standing question for this item. But Melina, take it away.
Yes, sir. So from that, we issued an RFI, and the RFI was to target vendors and partners that did not operate traditionally in healthcare, the traditional healthcare methods, but they delivered non-clinical interventions to map and map basic eligible population. From the RFI, we targeted, or we asked for specific focus areas. Those focus areas included diet, nutrition, and exercise support, health, literacy, and communication support, disease prevention and screening support, community health capacity building support, but they weren't limited to those four. When the RFP was conducted, from the information obtained through the RFI, we also included as a last bullet what we were looking for, that we would consider applications for additional priorities that weren't listed, but that identified with the same population of the Travis County Healthcare District. The RFP was launched in earlier this year. It is now in evaluation phase. We have received proposals, but notice of intents to awards have not gone out yet. And so that's where we are currently. Questions?
Thank you. Members, that concludes our quick update. We just, we recognize that you all allocated those funds, and it's something that we indicated we would work on this fiscal year, and just felt like we need to come back with this update.
Thank you very much, Mr. Giesland, Ms. Bunch. Any questions from the board? Oh, yes. Manager Valadez.
Thank you. I'd like to know whether or not will we be provided that list? And whether or not there's a way to break down the targeted population that each of these different applicants specifically deal with?
Yes, ma'am. Each of them that submitted their proposals identified the focus areas that they were submitting for. So we definitely have that information. And then once the notice of intent, once we negotiate the contracts, is the procurement is closed and it can become public knowledge.
Great. Just let us know. Thank you.
Yes, ma'am.
Manager Jones.
Just quickly, how widespread was this information provided in the community?
So we use the same process always when we advertise in our local newspapers, on the national platforms that we use. We use the state website to identify consultants that that registered in the area of being a consultant. And I can tell you that 27,500 were notified. 20% of those were hub vendors that were notified. 49 of them viewed the solicitation, and 5, which is 10% of the 49, represent hub vendors. Yes, ma'am.
Okay, so in looking at our Travis County demographics, how is that representative? Is that representative of our Travis County demographic for the populations that we serve? And not only, when I take into account demographic, it's not only racial or ethnic or non-English speaking, it's also where they live. So, so that we can know what their lived experiences are, who the population is that they deal with, and just assure ourselves as we work to make sure that Central Health is actually going to making root policy changes. You know, is that going to be something that maybe could be included in future reports?
Is that for those that responded?
Yes.
Okay.
Yeah, and for those that responded, because we can't control who doesn't respond.
I would, and
Except
I'll offer an answer, and then Belina, tell me what you think. But I think there's actually another staff person we probably want to have here. But as part of our hub program, I'm sorry, I'm focusing on you, but I'm managing this conversation in the other area. But as part of our hub program, that's the essence of what we need to do, is better data collection to know what's the diversity of those that are responding, and are they representative of the population that we serve. And but at the same time, Belina, I don't want to foreclose on anything that you're doing on the procurement side on this outside of the hub development. But is there anything that you feel is responsive?
So for the CHIF, what we're talking about right now, I don't have the solicitation pulled up in front of me, and I tried to, but I'm like not on the Central Health VPN anymore. But I'm almost positive that all of the vendors who sent in proposals are Austinites, because I think, and I'm not 100% sure, but I'm like 95% sure that one of the qualifiers or one of the criteria was that they are here in Austin so that they can be Travis County, so that and specific the population that we serve, and so that they can have hands-on with the population that we serve. So I'm almost certain, Manager Valdez, that those who propose are in the immediate Travis County area.
I appreciate that. The only reason it's not the only reason, but one of the reasons I'm asking this is because I have continued to ask, why do we not break down the possible hub applicants, and then those that come to us and say that they are now hub vendors, why we don't break, as we do with the males, what's your ethnicity, what's your race, what's your whatever. We don't do that with the women. And we don't do that with the females. In the females, I always felt like if you were a minority female, you were double whammied. If you were black or brown and a female, because all you needed to be was female, and you were counted. And if you're not in the male world, if you're black, white, brown, whatever, it's okay, you're counted. But if you're female, it doesn't appear to be that way. So I've always felt that there was an extra barrier that was imposed upon us as minority women. And they tell me, yes, the feds don't ask for that data. Well, the state doesn't ask for that data. And my idea was, well, Central Health, can we ask for it? Or are we limited by law to not ask for it because no one else does. So it's like, when do we affect real change? When can we make a difference? We can't do it if we don't ask the question or we don't push it. So at some point in time, that's just my comment. It's not for discussion for now, but if you all can understand that, thank you.
Thank you, Manager Valdez.
And Manager Valdez, we're working to make our hub reporting, especially since now we're going to be implementing the official hub program or making it better. We're trying our best to try to get as
For
much
equity
information. And, you know, we have to validate it. We can call if we had the time and ask, but we still have to validate it. We have proposals who still submit proposals, and because they are, let's just say, a Black female, they consider themselves as hub, but have not filled out the paperwork or gone through the certification process. So the only way that we can validate those is to pull the hub certification that's on file. And that certificate is really what the vendors have filled out. So as a woman, I'm just giving an example. I may feel like I may be in a better market by just saying I'm just a woman. Not sure, you know, so we are working to make it better. I promise.
Thank you very much. And there's also no motion necessary for this presentation. And last but not least, we're going to confirm the next Strategic Planning Committee meeting date, time, and location. So managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, August the 10th, 2022 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And at this time, I am ready to accept a motion for adjournment. Manager Jones, yes, thank you. And a second, Manager Musaitov, a second, and a vote, please. Everyone.
Aye.
Aye. And everyone voted. So yes, thank you. And it is 8:43. Thank you.
Thank you, Manager Brinson. We are going to return to the Board of Managers meeting. And I'd like to sort of give you a highlight of how we're going to conduct it from here. We have 2 agenda items left. Agenda item number 5, receive and discuss an update on Sendero Health Plan's financials and proposed business strategies, will not be taken up tonight. We will postpone the executive committee meeting and reschedule it for a later date. Okay? So that being said, I would like to, Manager Musaitov. Sure, that's fine. It doesn't, yeah, we still have a quorum. Thank you very much. Appreciate it. Thank you for attending. So the next item we take up on the agenda is the consent agenda. Consent agenda C1, approve the minutes of the Central Health Board of Managers June 15, 2022 meeting. C2, receive and ratify Central Health investments for June 2022. C3, delegate authority to President and CEO to negotiate and execute a consultant contract for the next phase of the Central Health's ongoing equity-based systems planning work, which includes developing operational implementation and financial sustainability plans in support of the board-adopted Health Equity Plan, also known as the Health Equity-Focused Service Delivery Strategic Plan, as recommended by the Strategic Planning Committee. And C4, discuss and take appropriate action on an amendment to the J.P. Morgan Chase contract for district depository services. Do I have a motion? Shannon? you pulling C3? We discussed it already now. Parliamentary question. The vote passed in strategic planning.
Correct. But that was just a recommendation of the strategic planning committee to the full board. Now the full board is voting on it.
I second his motion.
All right, we'll be here till forever. So, yeah, we will. So the motion is to pass C1, C2, and C4. I have a motion from Manager Jones. I have a second from Manager Valadez. All in favor? Aye. Any opposed? Aye. Any abstaining? Motion carries. We will take up item C3, delegate authority to the president and CEO to negotiate and execute a consultant contract for the next phase of Central Health's ongoing equity-based systems planning work, which includes developing operational implementation and financial sustainability plans in support of the board's adopted healthcare equity plan, also known as Equity Focused Service Delivery Strategic Plan, as recommended by the Strategic Planning Committee. Manager Jones. You pulled it, so.
I pulled because I want to speak out in opposition. I'm not supportive of that. That's the reason I pulled it.
Okay. Okay. Same with you. Any other discussion? Okay.
And I have to say,
Say it very quickly.
I'm going to say this very quickly. Thank you, Pedro. That we have the right as board members to pull any item that we want pulled, and we should not be made to feel any less than because we've done so. That's all I have to say. Thank you.
You weren't made to feel, it's just
No,
that it takes time.
No,
Thank you very much. Okay, so I need a motion to approve C3. Thank you, Manager Zamora. Do I have a second?
Second.
I have a motion by Manager Zamora. I have a second by Manager Brinson. Any further discussion? All in favor?
Aye. Aye.
Any opposed?
Aye.
I have one opposition, Manager Valadez. Any abstaining? I have one abstention, Manager Jones. Thank you very much.
Thank you.
We will now proceed to complete the regular agenda. Agenda item 2, receive and discuss a presentation on proposed Central Health fiscal year 2023 budget and tax rate.
A lot of the time, and I want to thank you all for your patience. As Jeff and Lisa are getting settled, I'm going to go ahead and just kick it off real quickly. This is to talk about the fiscal year 2023 budget. And through the Strategic Planning Committee, you have seen a lot of information around the priorities that line up with the strategic objectives that were adopted by the board. The vast majority of those priorities were based on the healthcare equity plan, again, seen in the Strategic Planning Committee. So we're not going to rehash a lot of what the foundational elements are. And tonight's really about the numbers. Now, we've also changed the format, which Jeff and Lisa will get into. So, we needed to spend more time on the numbers if for that reason as well. We'll get to the actual budget document. Overall, our expenditures, our investments, and healthcare delivery will go up substantially. Jeff will cover this by $100 million plus. Our administrative side of this, we have two major components to our budget: healthcare delivery and admin. Admin will go up approximately $9 million, but there are a number of big changes that are driving this budget that you see. We are obviously, as you know, in the direct provision of care, hiring more providers, but also everything that is needed to support those providers so that they're successful in technology and in additional support throughout the organization. Lastly, because there's the structure changes, we're going to spend a lot of time just talking about Schedule A and Schedule B and what that looks like. And you can see all the breakouts of expenditures. But in the future, when we come back to you, we'll talk more about service levels, how many people that we expect to serve. And a lot of that is already in the healthcare equity plan, but we want to come back and resurface it as part of the future conversations on this. Also talking about the little bit of, we'll have a list of the underlying business cases that help to build this budget, and also hearing from other executives about their departments, and then talking about changes in our workforce that are coming up in this fiscal year. Moving on to the next slide, proposed strategic priorities. As with each year, we try to narrow our focus and really look at what it takes to get exceptional to be able to serve our patients. As opposed to trying to do everything and be everything to everybody, you wind up being nothing to the people that you're supposed to be serving. So again, we're trying to narrow our focus. And so that's a lot of what you see here. Again, these are the strategic priorities that you've seen before in the strategic planning committee meeting that line up behind the 4 imperatives of access and capacity, care coordination, member enrollment engagement, and system of care infrastructure. Next slide, please. And all of this is built on the foundation, a solid foundation of financial stewardship. You know about our GFOA award that we've received in consecutive years. We have a very strong credit rating that is essential as we build physical capacity and use capital and use debt financing. Maintaining that rating is absolutely essential to our overall long-term financial strategy. We have a long-term forecast that provides sustainable funding for our care initiatives, and the care, maintaining levels of care year in, year out. We always want to be there for the people that we serve. So what we build, we need to make sure it's there for the next year. We do have one of the lowest ad valorem property tax rates of all the major hospital districts in Texas. And then we have a clean or unmodified financial audit statement since 2004. And again, those are going to be bedrocks of how we manage the fiscal situation for Central Health with the funds that you all ultimately approve. Next slide, please, and then I'll hand it over to Jeff and Lisa. So real quick, how did we get to the budget? I mean, we don't just take a set of numbers and say, well, let's throw in 3 to 5% for trend and call it done, and we'll put it in front of the board and see if it flies. That's not what we do. It is a very intensive process that begins right after we end the audit. And first, we come obviously to the strategic planning committee meeting where we set you all set the strategic priorities relative to the strategic directives that carry us through objectives rather that are set on a 6-year cycle. Each year we come back and tweak those priorities. And that includes work from the prior year. So for example, we're still going to be working towards finishing construction for the Eastern Travis County clinics that we've done groundbreakings for, but also working very feverishly to get it to the point where we can start something around Colony Park, for instance. So again, you'll see carry forward projects in addition to new initiatives. That leads to building business cases. So you have expert prepared cases that justify the changes based on sound business practices and risk assessment. Think of, those of you that have been around classic 7-section Harvard Business Cases plus. We've modified it significantly for Central Health to be in a healthcare environment where we're achieving health equity and serving the population below 200%. And so we always try to square up everything that we're doing with what is our mission? What is it that we need to be providing to those that we serve, and squaring up the business cases with that mission objective. And again, which I've already stated there in the second point. And then that leads us to, you put all that into the soup to the budget that you're going to see this evening. And again, being thoughtful about new initiatives and new spending and new investments, but also making sure that we are accounting for trends, because yes, there are inflationary trends, as you've been reading, that affect our budget. So with that, I will turn it over to Jeff and Lisa.
Thank you, Mike. Jeff Knoble, CFO, and Lisa Owens is here with me. I'm going to go over the next couple of presentations. I'm going to go back to the previous slide for just a second. So that gets us here to tonight. So there's a lot of work that goes into a proposed budget, but there are, and you'll see in our calendar, there'll be plenty of opportunities to go through the actual final approved budget. So in some sense, this is just a development process that gets us here tonight, but we still have a ways to go, many more meetings. You will hear tonight somewhat of a summarized presentation. We are just going to go through high-level numbers and you will see additional opportunities for more in-depth discussions on the actual services and what's behind the numbers related to future meetings, specifically around August 10th, our strategic planning committee meeting and a scheduled budget finance committee. So with that, Mike mentioned in the financial stewardship slide, the tax rate of major Texas hospital districts. We've updated the fiscal year 2022, both the tax rates and the overlapping taxing jurisdiction percentages for the major hospital districts. And the trend is still the same as we've seen the last numerous years. Central Health has the both the lowest tax rate you see at a little over 11 cents per $100, and then also as a percentage of all of the overlapping taxing jurisdictions, a little bit over 4.5%, and then you see the other districts ranging from anywhere from 11 to 27 cents, and then up to almost 10.5%. Next slide is talks about is a historical graph related around both taxable values in Travis County and the Central Health tax rate, which is the red line. We just recently received the certified tax roll, just like a couple of days ago. So we've calculated the tax rate based on the certified roll, which is good. The downside to it is we haven't had a lot of time to evaluate a lot of the other information related to that. And so we'll probably be bringing more information at a future meeting. But what I can tell you is not surprising. We've seen in the media all of the taxable values are going up substantially. And that's certainly the case. As you see in the blue bar on the far right, the taxable value has gone up substantially. That also includes a little over $6 billion of new construction, which is added to the tax rolls, which is substantial and still reflects the strong Travis County and Austin economy as an indicator of economic strength around taxable property. Just as a reminder, related around taxable value, most taxable value properties do not have caps on them, taxable value caps, other than homestead. And homestead properties are restricted by a 10% annual amount year over year. And then you as the board set what the homestead exemption amount is related to that. And we'll go over that shortly. The other prominent finding on this chart is if you look at the red line, you see a significant dip in the last year, and you will see that our tax rate is decreasing substantially in fiscal year 23. Next slide, please. Oh, thank you. So getting to the detail, specifically around homestead information and the tax rate, you see that the homestead value has increased substantially from 381,000 to 427,000, which is a little over a 12% increase. The tax rate from last year again was a little over 11 cents, and that's made up of the M&O, maintenance and operations, and the debt service component. You see our proposed tax rate, and again, this is at 6% over the maintenance and operation no new revenue rate is 9.87 cents, so it's a little bit below 10 cents. And you see the two components of that rate, the M&O rate and the debt service rate. And then taking the average taxable homestead value and calculating the actual tax bill, you see that the actual tax bill for the average homestead, taxable homestead value, even though the value has increased, the actual tax bill is going down by $3.84. And then, as I mentioned on the exemptions earlier, the 20% is an optional local exemption that the board approves and that Travis County Commissioners Court ultimately approves. That is the maximum value, and that the 65 and older and disability exemptions were increased from $100,000 to $110,000 this year. Next slide starts getting into some of the summary budget data. Again, these are just the numbers. Again, we'll have much more detailed meetings related to what's behind the numbers in future meetings, but just kind of orienting around attachment A. There are 3 columns: the fiscal year 22 approved budget, the fiscal year 22 estimate, and then the fiscal year 23 proposed budget. And again, you see the tax rates for both years up on the upper row there. Couple of things to talk about as it relates to our format. Mr. Giesling mentioned format changes. And so there are 2 format changes that I want to call your attention to. One of the format changes relates around the contingency reserve. And I'm going to point you to down at the bottom of the schedule where it says reserves, that you'll see a health delivery contingency reserve. That's what we're specifically talking about. So from a format change, if you recollect, previously we had combined the contingency reserve and our healthcare delivery uses in a combined line. We are reformatting this budget presentation and moving the healthcare delivery contingency reserve to its own separate line. That doesn't change any of the numbers. It doesn't change how the numbers can be used. It's really, from a formatting standpoint, we've had a lot of confusion in the past over our healthcare delivery, that specifically that line. And it really has, it's a combination of those 2 amounts. And it just, from this standpoint, I think segregating them will alleviate some of the confusion. As you look at trying to ascertain, do our healthcare delivery expenses, are they increasing and decreasing? And then you have the contingency reserve in there also that changes every year, and trying to tease that out. So we think that will alleviate some confusion that we've had in previous years. But again, I just want to reiterate that it doesn't change any of the properties of the amount. It doesn't change the constitution or the use of the amount. It's just a formatting change. And then secondly, we have always had a standing separate line, tax collections expenses, and we've simply combined that with administration. And so you see now the use we have administration in tax collections. It's just a single line. So hopefully that will alleviate some of the confusion we've had in the past related around the uses of healthcare delivery, as we just break those amounts out. And again, we've broken them out for fiscal year 2022, just for comparative purposes only. Couple of highlights, and then I'll turn it over to Lisa to go through some more detail. Our fiscal year 23 budget is, the healthcare delivery is substantially higher. It reflects the opening of some of our new healthcare facilities, both Del Valley, Hornsby Bend, and specialty care at Rosewood, Zaragoza. And in the vein of especially related around Rosewood, Zaragoza, this is a facility that really is our first facility related to the direct practice of medicine, even though we have a couple of specialty care lines or a specialty care line out. This will be a facility that will support the Central Health direct practice of medicine. That's going to entail approximately 120 positions that will be hired throughout fiscal year 2023. So we really are moving towards not only constructing facilities, but actually having the personnel hired and providing healthcare in the later half of this year related to those facilities. But it's a significant increase in number of positions that we'll have. And then, of course, they will carry over into future years at a much more substantial cost as we annualize those costs over the entire 12-month period. And then the other significant area is related around capital, just funding for capital projects and potential acquisitions. We provided some capital detail in our previous meeting, but we have others. We have the schedules in your appendix that we handed out, and certainly we'll take questions related to that. So with that, I'm going to turn it over to Lisa to go through attachment B.
Thank you, Lisa Owens, Deputy CFO. So I'm going to walk through the uses of funds, the $299 million that's listed here. It's broken into our two programs, healthcare delivery and administration. So just to highlight, as we change how we pay for care and how we start to deliver direct service, you are going to see some new titles and terms so that we can clarify the types of services. So as you know, the DSRIP program was in its final year this year. So the IGT for DSRIP next year is 0. And we've termed now healthcare services, as we're now providing purchased healthcare services and direct healthcare services. We've broken that out into two categories. But you can see the historical section of purchased healthcare services. That includes all of our contracted providers that you see in the monthly financials for primary care, specialty care, pharmacy, post-acute, all those areas. We're pleased that we have a $26 million increase planned in those areas with our contracted providers, significant increases in primary care as well as specialty care and other areas. As Jeff mentioned, and as you'll hear in our deep dives as we go forward, and you've heard about earlier this year regarding a capital project, the delivery of healthcare services at the Rosewood Zaragoza Clinic will be specialty care services. And this direct healthcare services section primarily highlights that initial effort. These are annualized numbers, as we talked about. We anticipate bringing on those providers in those areas later in the year, closer to when the clinic is opening, that there will be about $6 million in new investments for direct healthcare services at primarily in those clinical services area around the specialty care that are listed there. And then lastly on this sheet, you'll see the MAP eligibility. This was something that we're just bringing forward for potential changes to the MAP program. So our healthcare services are going up $132 million in that direct and purchased services area. I've also kind of tried to condense different sections of the report to just not have too much detail, but enough to show you where all the different programs and projects are funded. You will see an increase in our CHAP program, which is that first line. We anticipate the same enrollment with increased premiums. As we're winding down the campus demolition, those expenses you'll see are going down from about $5 million to $3.7 million. Then in the middle of this section, you'll see salary and benefits all the way down to other operating expenses. We do have more detailed slides, and we will be presenting extensive detail on program changes. Mike talked about those business cases. We will be adding significant new staff. It'll all be outlined at a department level in future meetings. But that is the clinical services that support the infrastructure of the healthcare operations. Data, technology, our new electronic health record for central health, and all the team members that support the service delivery operations, as well as launching the new direct services in those specialty care areas. And lastly, here, that making up the $277 million in healthcare delivery, anticipated $22 million for the UT affiliation agreement. Jeff did talk about the capital reserve. We gave an extensive presentation in June about anticipated capital. A slight change there later this year, and in your appendix, there is some final estimated proposed budget for Rosewood Zaragoza. It was a little bit higher than we anticipated, so we increased that just slightly to $49 million from the presentation that you saw in June. I think it was $47.5 million at that point. And again, more details will be coming on that project budget. We did approve an initial project budget for professional services to get that project started, but we have the full details of the project budget for you. In our administration area, we also, as Mike said, have combined the tax collection at the bottom there. However, the majority of this area is the administrative departments that support the operations of the organization and the government entity. We are going to be adding staff as well in this area to support the growing number of staff in the healthcare services delivery. Also, additional expenditures for consulting projects and known increased in planned projects, again, driving from those business cases that were submitted. Some of those impact our administration program. The majority impact our healthcare services. And lastly, I'd like to highlight a transfer of cash held for our self-insured employee health benefits. It's $2 million. So Central Health, the enterprise did move to being self-insured for our health insurance program for our employees. As that has happened, we would like to have some funds held for that fund to just manage the claims payment process. And so we're proposing that $2 million transfer there. So again, our total uses of funds are $499 million, $598. As Jeff mentioned, we will have lots more conversations and more details about what will this look like in service delivery. There are 3 community conversations that are happening in the next few weeks. I hope you guys can attend those. They are on our website. They're in the different formats that we've been offering and in different neighborhoods. And then August 10th, we do have a strategic planning and budget and finance committee both that day. Again, that's where you're going to see the deeper dives that we've been talking about. What do those investments look like? What the project budgets for new construction project at RZ and other details. But certainly if you have specifics that you want covered, please let us know. And then again, just all the meetings August through September to get the budget approved and the tax rate set ultimately by the Travis County Commissioners Court. So with that, I think we can entertain questions. And
Can I just make a closing statement? I'd like to thank the board for, we have, as Mr. Giesland mentioned, the board has taken a long-term look at our reserves and some of our long-term financial sustainability. And so I really appreciate the board looking at a long-term perspective so we can try to position Central Health to have the resources and the sustainability to provide the services that we anticipate having in the future. So we have looked at updating, and I think in the appendix you'll see we've slightly updated our chart to reflect our fiscal year 22 estimate. We also looked at the tax rate, and if we lowered the rate, would we still be within our targeted days of cash on hand. And at this point, we're still recommending a 6% increase over the no new revenue rate based on that long-term look. And again, it can be adjusted every year. It's just simply a long-term look, but we didn't see a lot of movement on the days of cash on hand at 6%. It's actually a little bit better, which is good, but lowering the rate just year over year dipped below our targeted days of cash on hand. So we feel like, from a long-term perspective, we're on the right trajectory. Sorry, it's too late. I can't say that word, but trajectory, and really appreciate the board taking a long-term look at our finances and acting accordingly related to that look. So thank you very much. Certainly happy to answer any questions or take any questions that you guys will have in writing. If anyone wants to send questions, we can certainly take those questions and try to come back on the 10th with both a good presentation and answers to the questions. Thank you all very much.
Thank you. Thank you, Mike, Jeff, Lisa. Excellent job, excellent presentation. Love the new format. I think that it will alleviate a lot of confusion with regard to the continuous funds. So I'm glad you guys did that. Members, any questions? Manager Valadez.
I'll set up a meeting with you guys to talk offline about some of these things, but I just want to kind of highlight a few things.
Okay.
I'd like to see the, you ask UT to itemize. Well, I think I'm one of those who's a line item budget kind of a person. And so just, it seems like it'd be very easy to break out the administration and tax collection number. It's easy. It would be easy to do. And I'm sorry. It's okay. I missed schedule it. I was looking. Okay, I was looking right here.
Okay, understood. Thank you.
Attachment A.
Jeff wants to respond to that right quick.
Okay, I was just.
One at
a time?
No, I want to point something out to you
Yes,
guys that, I think we're late in the evening and I think we're trying to get through the presentation, but I want to make sure that you guys understand, and I should have mentioned. So we've talked at length for a number of years that DESRIP is going away in the CCC. And so you will see a line item in attachment B. It's on, where is it? Sorry, my eyesight is failing. Yeah, so anyway, let me just tell you what it is. I can't see it. But this is our final year of DESRIP, fiscal year 22. In fiscal year 23, if you remember the UT affiliation agreement, the CCC is responsible for the payment and Central Health is the guarantor. And so we're looking at the anticipated cash flow in the CCC, and we anticipate that a portion of the payment can be made out of the CCC in fiscal year 23. But $22 million of the amount is in the Central Health budget, and that consists of the $35 million. So that's why you're seeing $22 million in the Central Health budget, is because, again, we've talked about winding down the CCC. And from a fund standpoint, that's why you'll see this portion. So sorry to interrupt you, Manager Valdez.
And I'm not expecting any answers right now.
No,
okay, but I did
that's
see
right.
that 22 million.
Right.
I did see the 22 million. I assumed 13 million was going to come from the 22, 15 million that is going to go away for the 23 fiscal year. Okay. I assume that, but I will get back with you. I have a lot more questions. I just wanted to gear you up for that. And my other key one for me is expanding map numbers and the ability for us as a board to look at eligibility requirements, especially for the non-citizen member. I just wanted to kind of look at that and see how much that impact for increasing those numbers is going to be on our budget, and whether or not any of that can come out from any of the contingency. Just giving you a heads up for when we have a private discussion. Okay.
And just as just a very quick response, the reserve that we have here is hopefully for increasing the eligibility period from 6 to 12 months.
For a year,
But-
finally, which I've been waiting for 2 years.
But the second part of what I'm going to say is this is because of the way the CCC, the agreements we have, it's not just a unilateral central
I
health
agree.
decision.
I understand.
So just wanted to make sure that.
Jeff, we've been talking about this for a long time.
Absolutely.
Okay, so
Just
anyway, we'll
any,
talk.
Any new viewers.
I'll
I
forward
just
my
wanted to
stuff to
point
you.
that out.
Thank you.
Thank you, Manager Valdez. Any other questions? Hearing none, I will take up agenda item number 3.
We can, I think, we can bring the financials back to any meeting, budget and finance.
Okay.
That'd be good.
Or the next board meeting.
We will take up agenda item number 3 at a later date. Receive the fiscal year-to-date healthcare service expenditures made by and accept the preliminary May and June 2022 financial statements for Central Health and Community Care Collaborative, and review historical average revenues and expenses for Central Health. The final agenda item is to confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board meeting is tentatively scheduled for Wednesday, August the 24th, 2022 at 5 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas, 78702. Do I have a motion for adjournment? Motion by Manager Valadez, second by Manager Jones. Any discussion? All in favor?
Aye.
It is unanimous. We are adjourned. Thank you, members. I appreciate it.
Thank you. Is Sherry, because she's virtual, unable to make motions?
No, she can make.
Well, because I was always expecting her. She's the queen of move to adjourn.
So I made a mistake.